And they can also get the plexiform neurofibroma here. So here you can see clearly the optic nerve on the left side. Right, so that's the optic nerve coming down. So that's there are different part of optic nerve, right? Can I use that? So you can see that's the intra. So there are different part of optic nerve when you describe. So behind the globe, there's part of the. This is all in the inside, right? So you need to tell the clinician where is located abnormality. So if something here, you can say at the orbital apex. When it comes here, it's intraorbital part of the optic nerve, and this is behind the globe, right? So retroorbital part. Then you come down, and this one here is a prechiasmatic tract, and then center is optic chiasm, and go behind is the retrochiasmatic tract, goes on both sides, right? Which was the abnormality we say on the last slides. And this one is the expansile lesion, which almost right here going to the optic socket and displacing the optic nerve. So that's the plexiform neurofibroma. And you can see some neurofibromas here on the side too, right, in the soft tissue. And they have a, not only in the brain, there are multiple neurofibromas throughout. So they are one of the neurocutaneous syndromes, right? So you get all the abnormal findings. The same patients. They have all the neurofibromas in the soft tissue right there. And you can see also on the occipital area in the soft tissue on the back, this large amount of neurofibroma. So this is what we have. So NF1, there's other name for it, right? If you remember that, von Recklinghans disease, but NF1 will work. Do you know which chromosome is located? So these are the autosomal dominant or recessive. These are the autosomal dominant, right? So it runs in the family. So one person has it, then it will screen everybody because everybody will get that. Also in the next generation, they keep coming, so they need to image every single family member here. So see, we talk about plexiform neurofibroma, they get optic pathway glioma, they get the sphenoid wing and occipital bone dysplasia. That's why there was expansion and there was associated neurofibroma. Right? That's why the one side was the exophthalmos, you see. White matter lesions which involve in the white matter tract in the cerebellum, but also you can see in the deep gray matter nuclei, globus pallidus, you can see in thalamus, brainstem, and they are very poorly defined. It's hard to find the boundaries. You define sometimes there is no mass effect. They can also get the vascular dysplasia, like stenosis, we had a case. They also get the dissection. So whenever somebody young patient with a dissection, we always think about in the mind that why patient got it, and you look for the neurofibromatosis. And this is a typical question they ask: which chromosome is located? Is chromosome 17? Okay, next case. This is your history here, so it should be easy. A 4-year-old with tuberous sclerosis complex. So what are we seeing? Easy case, right there. I give you diagnosis, so you just point out the findings.
Okay. Good. So this T1 anexia, T1 MRI of the head at the level of the both parietal lobes. We see both in the left frontal cortex what appears to be hypointense lesions, and also in the right parietal cortex. Imagine these are subcortical tumors. Yeah.
It's the same patient, right? You see the bright signal.
Yes.
So when you see the dark signal, you need to make sure that it's also bright on the T2 sequence. Otherwise, you look for what? If this is dark here and also dark on the T2, then Look for what?
Dark on
Both. If this is dark on T1 and bright on T2, right?
yes.
But let's say if it is dark on both.
Dark on both, then it could be a hemorrhage or calcification.
Yes, so to look for calcification, right? That's the calcified tuber. So here, so they get tuberous sclerosis, they get multiple subcortical classic. This is the classic appearance in pediatric patients. You know, you cannot miss this if you see this kind of lesions throughout the brain in the particularly going around the subcortical. This is what they call U fibers because it's like a U, you know, which is controversial, but it's a part of subcortical white matter. And then they get this. What are these?
So these are sub so again, so this is a T1 axial MRI of the brain at the level of the lateral ventricles. So noted uh hyper intense lesions. First of all, we see one at near the foramen of marrow, and the second one is in the left lateral ventricle. That's the posterior horn of the left lateral ventricle. They appear to be subependymal. So these lesions will be so yeah. So they are subependymal tumors.
Subependymal nodules.
Nodules. Yes.
So this is not at the foramen Monroe. Foramen Monroe, I like to be in the center here. That's the foramen Monroe.
Okay.
This is along the frontal horn of the lateral ventricle, right? So the linings of the ventricles are called ependyma.
Yeah.
Right? So anything along this is subependymal. So that's why they use the word. That's why same thing, right? If you have a tumor coming from the ependyma, this is called ependymoma.
Okay.
The same patient, right? You see the on contrast.
Yes. So they are enhancing.
Enhancing, right?
Yes.
So the tubers, you look for the enhancement. Why?
Tuber.
Why you need to look for the enhancement? Like let's say you scan the patient and you see these tubers. The next step is you give the contrast. Why we give the contrast?
So okay. So the enhance. So
will you stop here? Let's say patient has a tuberous sclerosis complex. That's the history given. And then you get this T1, T2, you got this T1 weighted images, you see the tubers, you see the nodules, and you say, okay, I'm done. It's okay, it's done.
No, obviously I wouldn't stop there.
Why?
The enhance means there's a chance.
You give contrast to just look at the vascularity.
Okay.
So
assistance here.
So you give the contrast to see whether the tubers are enhancing or not, as you said, but also you need to look at the size of the tubers because these tubers can grow and they can lead to what?
Sega.
What is Sega?
Sub.
Say the full form.
Pardon?
Say the whole yeah.
Subependymal giant astrocytomas.
There you go. Yeah. So you need to see that these nodules are getting bigger or not, and they get bigger over the time as the child is getting older. So they follow these patients regularly to see which one is getting bigger. Is it getting a hydro? They're changing. So that's why it's important to give contrast and measure tumor and subsequent MRI. So here is the patient with the subependymal astrocytoma. This is the tumor got bigger, right? So if you don't follow up, you will not find out. And the patients also can get the microcephaly. And what is this?
Subcortical T2 hyperintense.
Yes, so it's almost like going along the lines, right? You see the line like this is a bit confluent. So it's going in the, this is in the cortex actually. You see the cortex? So the question comes up, is the cortical or subcortical, and sometimes hard to tell, but this is a subcortical line going down there, and this is a cortic, right? Cortical. So because of the tubers can happen in the cortical area, that's why they get what? This patient, tuberous sclerosis patient presents with what? How do you find out? I hear something. Seizures, right? Because it involves the cortex. Right? So these are the radial migrating lines, and so this is basically heterotropic glia, right? In the expected part of the cortical migration. Remember, these are all the autosomal dominant disease, right? So it is when the brain is developing, all these things are happening because of genetic expression problem. Can I like click here? Okay. This cannot, it's not going away, right?
Yeah.
This message here, yeah.
It's on the other screen.
Oh, here. Okay. No, but it's not going from there.
That's all right. Okay.
Interesting.
Okay. We can go on.
Okay, there it is. Okay. Okay, so tuberous sclerosis is the inherited tumor disorder with the multi-organ hematoma. And what's the base tag? You see the calcified subependymal nodule. Remember that first nodule can also get calcified. We talked about cortical, subcortical tubers, and we can see the mass at the foramen of Monro, right? That's the. Do you know what grade is a tumor is? So different grading, right? The WHO grading.
It's a low grade.
Yes.
Yeah.
And that's the reason you follow, because if it is a high grade, you take it out, but these are the low grade tumors, that's why you need to follow, because they slowly get bigger. And why it is important? Because the subependymal giantoblastoma at the foramen Monro, it can cause obstruction, right? So it can cause hydrocephalus in the pediatric patients, and brain is still developing. So it can be, if they're growing too fast and they come with the symptoms, increased intracranial pressure, they might need to take it out or put the ventricular catheter, right? So see tubers 90% in the frontal lobe. You can sometimes see the flame shape, like going down like a triangular shape. Sometimes you see that. And we talked about this. And 90% patient with the seizures. So the important thing is pediatric patient, very young with the seizures, you look for tuberous sclerosis. That would be always need to think about it. Okay, next one. Back row. I like that. Everybody answering from the front. What's your name?
Able.
Ibu? Which year are you in?
What year?
What year?
Final year.
Final year. Okay. All yours.
Okay. So this is an unenhanced ASIAL CT scan of the brain at the level of the centrum semiovale. I'm noted in the posterior aspect of the left parietal lobe are these gyriform hyperdensities, be likely calcifications. The right cerebral hemisphere is unremarkable. So are there any other imaging modalities?
What's the diagnosis?
Okay. So for differentials for Gariform calcifications, I'll give Sturge Weber.
Yes. So this is typical Sturge Weber, right? You can, so important point here is there is no much volume loss here. And it's typical Gariform appearance, right? So if and most of these patients are pediatric patients, right? So you cannot make mistakes on making no diagnosis here. You need to make this diagnosis. And the same patient, right?
Yeah.
You see the more calcifications throughout the cerebral hemisphere on the one side, right? That's another point. And then what is this here?
So this is contrast enhanced T1 weighted MRI. It shows some hyper intensities in the posterior aspects of the demonstrated parietal lobe, appear involving the cortical areas. When you come a bit anterior to that point, you can see some enhancing vessels. So I think there's some maybe leptomeningeal enhancement at the posterior aspect of the left parietal, maybe in a bit of the occipital lobe.
Okay, so with the Sturge Weber, if this is a Sturge Weber, what is this? These are called what? See, all these vessels you say is leptomeninges, right? So what is in leptomeninges? There's a subarachnoid vessels, right? But this is going deep down on the surface throughout. So this is PL.
Okay. Yeah.
So this is Sturge Weber. Sturge Weber is encephalotrigeminal angiomatosis. It's a congenital syndrome, right? Where what happened in that the cortical veins fail to develop normally, and because of that, remember yesterday we talked about there are 3 layers of meninges: dura, arachnoid, and PI. PI you cannot see on MRI, so the PL, all the veins over there get angiomatous changes, and also it can go to choral plexus, and that's why you see that appearance of PL angiomatosis. They associate with the patient has a facial cutaneous venous malformation, so typically you have a stain on the face. Most of the time, radiology, the problem is we don't see the patient. So when you see the images, you need to ask clinician, do you see something? Or sometimes they put an indication, there is a stain. Sometimes they put that is very useful for us. If not, you can call and ask. So that's the PL angiomatosis, serpentine leptomeningeal enhancement, unilateral. In 80% of the cases, when it comes to bilateral, that's where the problem happens, because most of the cases we see is on one side, right? Unilateral, and that's where 20% of the cases. But then you try to ask the history and try to look at whether there's any facial, cutaneous signs are there, that helps to diagnose. We had a case yesterday, and I think on that one I saw there was a lack of cortical veins on MRV, if you remember. There was a prominent, so because of the lack of superficial cortical veins, all the deep veins try to take over, so you see a lot of collaterals from the deep veins. So early finding, remember the first image, we have some calcification. So this usually happen later on. So early cases, you see only the PL angiomatosis, like angoids, choral plexus, you can see. And the late finding, then you see the atrophy of the white matter, and then calcification comes in. And because of that, right, patient may have seizures because again involve the cortical area. So look at here, PL angiomatosis may be occult if no facial lesions. So patients have no facial lesions and no seizures, then it's pretty hard to diagnose, but most of the patients have facial lesion visible at birth. If the facial lesion on one side on the face and you see this imaging, you know what is the diagnosis. Look at here, seizures develop in the first year of the life. So again, look at the pediatric patient, the seizures, and you see, then you can make a diagnosis. Remember, I said this case is you need to diagnose. So very good. Della, right? What's his name? Ebu?
Yes.
So here's the just On MRI, you see this is one side, all the leptomeningeal vessel enhancing on the right side, and there is a choral plexus engorgement. And you can see the same thing on coronal, and this is the sagittal post-contrast sequences, and you can see the same thing. So this is pretty unique appearance. Keep this in the mind that sometime if you're diagnostic dilemma, look for choral plexus. If there is a choral plexus engorgement, that's the developmental problem. All these veins develop together. So all these deep collateral vessels comes here, and that's why it's a PL angiomatopathy. Okay, next is the hypoxic ischemic injury. So imaging finding in the hypoxic ischemic injury is very variable, and it all depends on the number of factors. It's a preterm, term, the severity and duration of the insult. When you image also matters. So generally, it's because of these are the newborns or the preterm or the term babies. You look at the T1 and T2 convention. Most diagnostic. But the problem because of the myelination, right? So when by the 1 week, when you find out that there was something hypoxic injury going on, the image is really late because they're trying to resuscitate or trying to stabilize the babies. And by the time you get at the 1 week imaging, or diffusion weighted images are usually normalized, right? Remember, we have that fog phenomenon happen when the stroke happens. You see bright on diffusion and dark on ADC, but slowly the ADC goes up and diffusion goes down. So it's normalized and it's hard to tell, right? So that time the T1 and T2 weighted images are most useful by the end of the first week. Okay, so this is a severe injury. Can somebody take this?
So this is a single axial DWI image of the brain, and it's at the level of the basal ganglia. And the black arrows are pointing to bilateral, fairly symmetrical, high DW signal within the lateral aspect, anterolateral aspect of the thalami bilaterally. And so with this, I would like to ask if I can get an ADC. Right, so the companion is an axial ADC map of the brain at the same level. And the arrows we demonstrate a low signal on the ADC map, and together indicate that there's restricted diffusion. So yes, so with these bilateral symmetrical restricted diffusion within the thalami bilaterally, I would make an impression of severe hypoxic ischemic injury. It could also be a bilateral infarct, which is unlikely because I would have expected it to be more global in the thalamus. Yeah.
It's the same patient.
Right. So still axial DWI image of the brain, this time higher up, somewhere around the centrum semi-ovalium, we see deep white matter, high signal on the DWI. There appears to be extension of this high signal also to the cortical surfaces of the bilateral frontal lobes and parietal lobes.
Inpatient ADC.
The companion ADC shows low signal in both cerebral hemispheres as described in the DWI. So with all of these findings, I'll give an impression of global hypoxic ischemic injury.
So when we say about the thalamus, it's the ventrolateral thalamus and posterior of the internal capsule. This is both hard to separate it out because the way is outlined on the both sides. This involve both because those are the area hard to differentiate out in neonate. And this is the peri-Olympic area where you see we talked about yesterday, remember the motor cortex and the sensory cortex. So this is where it is involved. So this is a highly metabolic areas, right, at the neonate. So that's why this area get severely, if the severe hypoxia is there, they get affected. That means when you say that it is severe, that means that it affects the prognosis. So you always need to say it's a mild to moderate or severe, you know. So when you see this classical appearance, that's severe. And then as keep progressing, you can start seeing the more signal intensity in the basal ganglia. So you can see in the basal lentiform nucleus, and it goes to other part, you know. So, but these are cerebral peduncles start getting involvement from posterior limb and go further down. But it involves the corticospinal tract, you know. So that's why you see this signal intensity. So this is what you see in the severe hypoxic ischemic injury. And the next one is the partial. So here's the diffusion weighted sequences, and you see the bright signal. So these are located in the frontal lobe, parietal lobe, right? This is all the way higher up. You see the little bit part of the body of little ventricle. So this is at what distribution? This is called?
So it's distributed within the frontal and then the parietal lobes.
Yeah. So this is what is we call? There's a word for this, right? This is watershed distribution.
The watershed distribution.
So when you see in water, so that means when you say watershed distribution means it's involving both, right? It's not involving just one branch, it's involving bilaterally. So that's why you see the abnormality on both sides. And this is involving in the cortical and subcortical white matter both, right? Then other one we had only involving on basal ganglia and the part of the corticospinal tract. And the same patient, right? We have this bright signal and dark signal. So that correspond restricted diffusion. And again, this is on the T1 sequences, you can see this all in the white matter areas is all dark areas. Remember, we need to see yesterday we talked about myelination, right? So the area is supposed to be start getting brighter, right? So that's why it get very challenging to look at when this normalize, then you are reliable on T1 and T2. And this is what you get at the end. If this partial neonate hypoxic ischemic injury patient survive, then slowly they get this called periventricular leukomalacia, where it's a little bit bright signal around the ventricles and ventricles a little bigger. That's what you get if they come out from this hypoxic ischemic injury. But the severe one usually are very bad prognosis. So here see the same area, right, on the CAT scan, and then you do the diffusion. So this is called mild to moderate. Remember the severe one? So always you can tell mild to moderate or severe that's how you tell the clinician because they want to know what is the prognosis. They cannot tell clinically, you know, because they are will be intubated and they do the MRI. How severe is the injury? Same thing you do for the patient with the cardiac arrest, right? The patient has a arrested resuscitated for 20 minutes, 5 minutes, 10 minutes. They don't know how much damage happened to the brain. And they determine the prognosis. That's why they do MRI. If there's a severe injury, it's unlikely it's going to come out. You know, if there's a mild to moderate injury like this, there are chances that you will be doing a little better than severe injury. But still, once the injury happens, the prognosis is not good in either way. But severe one is very lethal. Clinically, they want to know two things. First of all, injury is there or not. Second thing, injury is there, then how severe is the injury? And only you can tell with the MRI. Sometimes you see with the CAT scan, sometimes CAT scan you might not see anything. So here is the diagram, right? Suspected hypoxic ischemic injury. If it is neonate, you do the head ultrasound, right? Easy to done. If it is negative, then you do MRI. If it is positive, you stop there because you're going to find the bleed. So you stop there. If the MRI is positive, then you know you stop. If it's negative, then still they're clinically suspicious. You can repeat the scan in 2 to 4 days because you might not think the enough edema or enough metabolites there to give you the finding. Same here on the side, infant, older child, or even in adult. with a cardiac arrest, or you looking for hypoxic ischemic injury, you do the CT scan right there. Everybody does a CT scan first to look for bleed, look for there any herniation there or not. If it's positive, then you can make a diagnosis and stop there. If negative, then go to MRI. Sometimes the positive scan here, they still go to the MRI because they cannot determine if it's severe or mild to moderate. And remember, delay MRI, the 1 week may useful, right? They sometimes do the MRI later on to see how much damage is already happened. So they might repeat the MRI after 1 week. So it's just one other case where you see the diffusion weighted sequence. This is ADC, the bright signal in the bilateral. Where is this located? What? Yes, so paramedian frontal lobe, right? And the corpus callosum in the front and posterior, both are involved. And also there is a abnormal signal here in the temporal, parietal, both sides, right? More on the left side. And then patient also have a subdural collection. So sometimes you don't get the classic just so there's a hypoxic ischemic injury and you just get all the ischemic findings. Sometimes you have bleed too. So you get combination of both. Okay, next one is infection. So in congenital infection, we talk about TORCH. You know what is TORCH, right? I put one here, toxoplasmosis. What is O? No? Toxo, right? The second one is, then? All right. I put the syphilis there. Yes, others, HIV. Remember the HIV can happen in the babies, right? When they're born. What are the 3 ways HIV can transmit? Mother to child, so placental transfer. What else? I can one person. What? Blood to the via blood, right? They do. And the third one? Journal. Yes. So 3 ways, right? You got confused. Okay, so so timing of the infection during the fetal development, it happens, right? All this infection. So when you get the early insult with the torch, you get the brain malformation, which is important, right? Because if they get the infection when they are in the development phase, right, the brain will not develop properly. So in the late insult, they get all the destructive changes. So here, this is what you get. You get calcifications because it's already late when they come out, right? When they're born, the infection already happened. So we talked about this yesterday, right? The CMV, the periventricular toxoplasmosis, remember? Basal ganglia, so we see that. They all come with how clinically they know they have infection? They look at the head circumference, right? That's the typical pediatric assessment, right? They measure the head circumference every time they go to check it out in the starting few weeks. That's how they know it's a microcephaly or not. And then they image, because they're looking suspicious that there's something else going on. So then you get the ventriculomegaly. If there's a infection happen that time, then you get all these congenital brain malformation, polymicrogyria, or the schizencephaly. What is schizencephaly? Left line by, and it can be so here. This is a CT brain, and what do you see here? Now, once you see this, can you tell that what kind of infection patient has? Most likely CMV. Sometimes you cannot. right? Because all the infection can cause you calcification. The other thing, there is hydrocephalus. The ventricles are bigger. So that's the other finding you need to make. So you get the intracranial calcification. So in the pediatric patients, you get the CT brain calcifications. Think about the thought. The same patient, you get the abnormality like this. What is this? Anybody? Did you? I don't know. I hear or not, but did you say something about the cortex? How is the cortex? Okay. And there are more gyri, right? Yes. So we have this cortical abnormal thick cortex, right, and the multiple gyri. So that's your polymicrogyria, right? And then you have a hydrocephalus. And so this, when you see the cortical abnormal, again you think about this because of the infection, right? So they get the, sometimes you just get, instead of this like multiple gyrus or polymicrogyrus, sometimes you just get the smooth cortex throughout. No, there is a gyri, so that's called lesioncephaly. And sometimes you get just one area abnormal, that's the cortical dysplasia, or sometimes you have multiple like this. And schizencephaly, right? You will see you guys all know the schizencephaly, where you see the CSF flap going down there and it's aligned by the gray matter. What's most important is the hydrocephalus is there, right? So when you see pediatric patients, not all the hydrocephalus, you need to look for tumor and they're going to go and intervene. Sometimes it's congenital like this. So if you tell them there's a hydrocephalus and there is a cortical abnormality, we say most likely it's because of congenital infection. So they will understand this has already happened. They cannot do anything more. So sometimes you can see here there is an extensive calcification throughout, right? Along the cortex and here along the ventricles. So sometimes hard to tell what infection happened. Okay, I think this is the last case. Well, this image is a little blurry here, but somebody can diagnose this case. We're taking time. Oh, you. Can you remind me your name?
Senor.
See?
Senor.
Senor?
Yes. Okay, so with a series of MRIs. The first is, I think it's a T2 image.
T2, yes.
Yes, and the second is a DWI image. The third is a T1. No,
Okay.
yes. So the upper images are axial images. The fourth image is a coronal T2 image. And then the fifth image is a ADC. And then the sixth image, I think you also have, it looks like a flare image. Oh,
The last one?
yes, the last
F?
one.
F it's a contrast.
It's a contrast.
Post contrast
T1
T1.
post.
So here is a T2, right? The left side, this is T2 axial coronal diffusion ADC, axial T1 pre and post contrast.
Okay. All right. So starting with the diffusion-weighted images, there is an abnormal area of restricted diffusion involving the right parietal-temporal, so parietal, temporal, and then the occipital lobe. Also includes the the splenum of the corpus callosum.
Yes.
These areas appear hyperintense on the T2 weighted images. And on the T1, it also appears as areas of increased cortical intensity. And then there's no significant enhancement on the contrast. Oh,
So this is pre, right?
yeah, this is a pre.
And this is post.
Yes.
So there is an enhancement, right? This is the pre, and here is all the enhancement.
Okay.
You compare right and left, so you see there is a more
Yeah.
leptomeningeal enhancement here, right?
Yes.
So what is this?
Um,
Pediatric patient.
So for a pediatric patient with these areas of restricted diffusion and increased enhancement, I'm thinking a cerebritis or encephalitis,
Okay.
which could be secondary to an infectious cause. So likely one of the touches infections.
So you're doing good. At the end, you twist a little bit. So you say right, this cerebritis or encephalitis. I like that. Which part this is involving? This is the temporal lobe involving, right?
Yes.
So what is common when you have temporal lobe? We think about encephalitis. We talked about this yesterday. Because of high mortality, right? What is that called? Herpes
Simplex.
simplex. And which one is there in adult population?
Which one is?
Which one is this?
I think
This is pediatric, right?
Yes.
So HSV type 2 you get in adult, and type 1
One.
in pediatric. So this is type 1. Very good. Okay, so that's the one. We are on time. Right. Continue or what's the? It's up to them. I don't. You don't want to continue, break? Lunch. Oh yeah. 5 minutes. Okay. This is like it. Then it's all about your
break. We'll take a 5 minutes break, stretch our legs a bit, and then continue. Thank you.
Things we can do, either we can start stroke or get the case discussion. Let's what you guys in mood for. Stroke? Okay. Okay, how many people are online? How can I know? You can see here. Okay. I'm on. Okay, everybody, we are back. The next one we're going to talk about stroke. So the goals are we're going to look at the different modalities for stroke imaging, imaging appearance of the stroke, which is very common. I'm going to explain some advanced neuroimaging methods which we typically do in day-to-day practice. And over there in the hospitals, the way it works, the patients come with the stroke alert. So anytime patients come, usually with the ambulance. So ambulance usually they call an alert. And so before the patients even come to the emergency room, they announce in the hospital that the patient is coming, is on the way. And there are two different kinds of centers. One is the stroke certified centers, another one is a comprehensive stroke center. To get the stroke certifications, they need to follow these guidelines. Otherwise, they don't certify those hospitals as a stroke centers. So the emergency, the ambulance cannot take the patients over there. So once in the field or they get the call over the 911, so the ambulance goes there and they alert from there it started and they tell the emergency room, whatever the nearest hospital, we are bringing the patient with the stroke because they make a diagnosis on they may be wrong, they are just emergency medical service personnel. So we get alert that stroke patient is arriving in 5 minutes or 10 minutes. So all the teams are prepared. The emergency medicine teams will go at the gate where the ambulance is parking, and they put the patient on the stretcher or patients coming out from the ambulance, and they examine over there and decide. First of all, they will examine whether the patient is stable or not. Or most of the time, EMS give them the idea that how stable is the patient because they already check the vitals, start the fluids and everything, get the IV line. And at that point, emergency physician will decide the patient is going to the emergency room or patient is going directly to the CAT scan. Because the most important thing they want to find out is it bleed or not. Right? So the radiology department is also, because the overhead announced, they also know the stroke patient is coming. And they usually they have a slot open. If the stroke patients come, they will take them first. Like trauma centers, there's always one scanner is open, they need to take the trauma first. So they usually have two scanners at least in the trauma center, one for stroke, one for trauma. So stroke center, that's a priority because they need to image. So there's a timeline. So they calculate all this time from door to CAT scan time, door to TPA time, right? The clot breaking medicine they give, door to embolization time. So they do the CAT scan and then they decide which direction patient is going. If they go for patient is to transfer for the declotting to the angiogram, then there is all this center says a helicopter on the backside. So they transfer the patient from there directly to the comprehensive stroke center where they can alert the team before transferring that we are sending the patient, they are ready over there, and they take in the angio suite and try to embolize, try to do the declotting. So this is how the things work. So In radiology practice over there, we are doing this 24/7, and we also need to fulfill the timeline that we need to report the non-contrast CT brain in 15 minutes. So at the end of when the patient discharged, we get all this reporting, and because I am section chief, we get all this reporting, who didn't report it. So if one of the radiologists didn't report it in time, we need to bring him down and talk to him that this is our guideline, this is our practice, and you have to report. So everybody reports in 15 minutes, the non-contrast CT brain. But it's not only reporting, they need to pick up the phone or send the chat message via internal system, and they need to acknowledge the message, the EDP, yes, I got your message. And they need to document in the report that, okay, you look at the finding, there is a bleed or no bleed, because if that doesn't happen, then the treatment doesn't start, right? So it is always little stressful over there, but the way we structure that, everything works smoothly, because everybody knows this is expected, and they also do same thing in the training. Even after hours, we send the scan to the outside in the like teleradiologists looking all these studies, they also report in 15 minutes. So with that understanding, we're going to look at the stroke. The stroke has three main etiology, right? There's the infarction, 87% of the cases. Look at the hemorrhage in only 10% of the cases. And the subaqueous hemorrhage is also one of the cause, right? In the 3% of the cases. So what is the imaging of active stroke? We're looking for rule out hemorrhage. Also, we're looking for other causes of the stroke. Sometimes clinically they think it's a stroke. You look at the imaging, so this is a tumor, right? So you're looking for other things too. Also, try to find the etiology for ischemic infarction, because stroke is a clinical diagnosis. So they know there's a stroke, but you need to know why there is the ischemia happen, right? Remember, time is the brain. That's why similar way the patients come with the chest pain. I don't know how here, but over there the chest pain and the brain's stroke code, they take it very seriously over there. They think the more early you intervene, you get the better outcome, right? So that's why they are always on the alert. So how it is here? Do you guys get the alert for the stroke? No. What about this? Send the patient to CAT scan right away. Yes. Send the patient even like in the evening time. Do you know what is the most common time the stroke patients come? What? No. Early in the morning. The stroke, most of the time, the stroke patients come early in the morning. So usually it happens around 3 to 4 a.m. And by the time you get to the hospital, 6, 7, 8. That's typical time the stroke patients come. And there's a reason for that, because remember the CSF, the cerebrospinal fluid. Do you know where it is formed? The CSF formed inside the coral plexus, right? So once the fluid forms, it goes around the brain. It goes at the top of the brain, right? Where the arachnogranulations are, it gets absorbed over there. The same fluid goes around the spinal cord, right? And it comes back up. How it comes back up? So CSF is there, right? Around the brain and spinal cord. So every time with the cardiac cycle, it pushes the fluid with the venous pressure, the fluid will comes up. So it's constantly cycled, right? So the fluid is constantly circulating in the brain and spinal cord. Do you know how, let's for example, the blood we form, the red blood cells, right? It takes how many days to form the red blood cells? How much time it takes for the CSF to form? Yes. See, I need to know this, right? Because I do CSF leak repair. So CSF form 180 to 300 ml, everybody forms in 24 to 48 hours. It's constantly changing. That's why you go for sleep, you wake up, you are fresh because your neurons are fresh. The CSF is fresh. That's why it happens early morning. The stroke, all the neuronal changes happen early morning. That's why most of the time stroke is present that time. It's not at 8 o'clock patients come, because patients coming late, it's usually at the 3 or 4 a.m. in the morning. Okay, so the clinical symptoms, right? So clinically, they can tell, right? Patient is what kind of weakness. If there's a leg weakness, incontinence, they're looking for anterior cerebral artery. The most common is MCA, right? Medial cerebral artery supply majority of brain. It's a face and arm weakness you get. Commonly come with the aphasia. There's a neglect on one side of the body. The PCA, the posterior cerebral artery, come with the hemianopsia. You know what is hemianopsia? Yesterday I gave you homework, right? The front, when the anterior frontal are closed and when the posterior closed. Did you guys read about it? No? Okay. So I'm going to ask you again in the after lunchtime. Same hemianopsia. I need to find out what is it. Okay, I'm going to ask. You can Google, but I want you to Google so you remember, you know. Okay, so the PCA, right? And then the cerebellar stroke, all these posterior inferior cerebral artery, anterior inferior cerebral artery, and superior cerebral artery, right? We talked about this anatomy yesterday. Once the both vertebral artery goes up from the basilar artery and the branches come out is the PCA. And then the next branch comes out to the superior cerebellar. Then ICA comes out and the pica comes out from. Pica is a branch of what? What? No. Pica comes out for vertebral. You need to know the anatomy. The pica is, so if you have pica aneurysm, right, you look for the vertebral artery because it's going to come out from there. So this is important because it has a particular area get involved in the stroke, right? So you can tell which distribution is involved. And there was a case I think yesterday where I asked you which part of the brain is affected and you answer correctly. Remember there was one side of the weakness and patient has a cranial nerve palsy. So that time look for brainstem stroke, right? So same thing here. The patient has a facial numbness and all these symptoms, the dysphagia, Horner syndrome, dysarthria, and ataxia, right? So this one is looking for cerebellar stroke, right? So you need to have all these. And so clinically they know that what areas they're looking for. See, the cerebellar comes with all these symptoms and the middle cerebral artery comes with the body weakness, right? Leg weakness, arm weakness. Clinically they know. So if you're the one side cranial nerve palsy and the frontal motor deficit, that's where you're looking for the brainstem area. Okay, so this is what we see, like early signs. What is this here? Yes, do you see this? Yes. Everybody, even for the first year should know this too, you know, because this is the first sign. And I even nowadays I still see this. This is stroke and this is the only thing sometimes you see, just a dense MCA. So look for it. If you look for it, you will find it. And if you ask them, you said, yeah, I have all this weakness on other side. And if you don't intervene that time, then it's going to expand and involve the whole artery, you know. So it is very important they give the TPA right away. So this is a hyperdense MCA, right? And why we see the hyperdense MCA, what is the reason? Because of thrombus right here, right? So thrombus can be look bright on the non-contrast CT. That's why you can see it. Similar like a blur, right? It's a high density. So you don't see in all the cases. You see in 35 to 50% of the cases. 50% is a lot. So are we not looking carefully? No, because whenever the stroke happens, we look at all the cortical areas, right? There's a hypodensity or not there, but nobody pay attention to the hyperdense MCA, you know. So, but you see it is very common. The next thing you see is this other sign. So that's called insular ribbon sign, where you can compare the insula. Remember we talked about insula yesterday. This is the insula right here. And so you look at the other side and you see this loss of differentiation of the insula. You see the hypodense area. You can miss this. The only thing you look for, I don't know how how you got trained to look at the CAT scan. The CAT scan, when you're looking up, you look at the sulci, right? So you look at the sulci on the right side versus left side. You lose the sulci on the left side. So that's where you call this is sulcal effacement, and then you start seeing the hypodensity. Otherwise, you will miss the hypodensity. So that's called insular ribbon sign. If you image early in the first 3 hours, Then you see it. Now that's caused by cytotoxic edema. Do you know the difference between a cytotoxic edema and a vasogenic edema? What's the difference? And where do you see vasogenic edema?
In tumors.
In tumors. Okay, so even on non-contrast CT, you can tell them, right, what you're looking at it. And then if the time progresses, you can start seeing the more sulcal effacement. And this is the only thing you see in early. This is because of cytotoxic edema. And if it is keep progressing, then you can get this big hypodensity. By the time this happens, already many hours pass. Definitely less than 24, sometimes more, but then you start seeing more. Always look at the symmetry, right? That's the good thing in neuro. You can look at right and left. Compared to body, you have one liver. There is no other liver, right? So in the neuro, is the advantage. If it is a unilateral abnormality like stroke, you can try to compare other side. Give you a lot of hints. Okay, so this one is 60-year-old with the history of stroke 10 days back. So what we see here, this is a hypodense area, right? And there's a loss of gray white matter differentiation. There's a, looks like almost like a triangle area, waist shape area right here. And then you give contrast. When you give contrast, you can see the enhancement. We talked about yesterday, right? The subacute stroke can enhance. How early it can enhance? When it starts showing enhancement. Two, 2 to 3 days, it starts showing enhancement. It can be peak at 2 weeks, and then it can last for 2 months. So that was the subacute, say the history of 10 days back. Now let's say if the patient come with a stroke and you've only got this, right? And then so it's a stroke, but you cannot tell that this is the old stroke or the new stroke, right? How will you look at that? You look at the Hounsfield unit or density, right? You guys measure density. And you sometimes if you don't measure, still you can tell because it looks like a CSF density. So it's hard to tell that this is a subacute stroke or the chronic stroke. But if you give contrast and if you see enhancement, then you can tell this is subacute stroke. So this is a typical distribution. The ACA infarct, ACA territory, right? Anterior cerebral artery involve the paramedian frontal lobe, and the posterior cerebral artery involve, what is this area? Thalamus. So that's the ventrolateral thalamus, and then it goes here, inframedial temporal lobe and occipital lobe, right? That's the territory it involved in the PCA, and this is involved in the ACA territory. So you need to remember how the ACA infarct looks, how the PCA looks. Most of the PCA or ACA infarcts are what compared to MCA? The MCA infarct you're looking for involvement of the clot in the middle cerebral artery, right? That's the most common. So it's coming from heart. So most of these patients, if you say PCA infarct, they most next thing they will do is the cardiac echo. Do you guys do cardiac echo here? Yes. Yeah, same done by cardiology. Though I learned when I was learning ultrasound, but over there they are the one who does it in the outpatient. So it's in the hospital too. Okay, so now is the time for the case. 10-year-old. Yes. Oh, give me the money. Okay, we have a question here.
Yes. So far the images you've shown, the CT scan is in the brain window. I want to know how useful the stroke window is in looking at these, because it's just the brain window we'll be looking at. Do you when do you do the stroke window, and how would that help you more as against just the regular brain window we do?
Good question. So where I am practicing, where we have a non-neuroradiologist also, we are not neuro trained, and I think 7 years back or 6 years back, we had a lot of cases where get missed. They were not picking up the findings of the non-neuro people of acute, like small stroke or hyperdense MCA. So we do a stroke window in every single CT brain now. So we have this regular brain window, and then we have stroke window. We label as like brain 2. So you get 2 axial images. Doesn't matter patient has a stroke or not, every single one get it. Because it's hard to implement, because sometimes technology doesn't know which one patient to do it or not do it. So that is very useful. And because we started doing that, everybody is like finding it out. So our missing rate is way below now. Nobody's missing out the stroke. So good question. So when you look at the CT brain, always window a little harder and try to look at the dense MCA. When you start looking the dense MCA, you need to window harder. Otherwise you will miss. So that's a very good question. So okay, this case, 10-year-old.
Okay, so these are two axial CT scan images, both at the level of the centrum semi-ovale. I think the second one is a bit higher up. So noted in the right centrum semi-ovale is this abnormal hypodense area. I would like to check the hands for unit to see, but I would assume that this would be more close to CSF. The second image also shows the same lesion in the same region. So the contralateral hemisphere is grossly unremarkable. So with this finding, I'll make an impression of maybe a chronic infarct. I suspect it to be more in the anterior cerebral artery territory.
You see the patient's age?
10 years with left side.
Do you see stroke in the 10 years old?
Very rare. We don't
No,
see
right?
it.
Okay. So do you see anything else? This is not contrast CT.
Yes.
The patient came with the seizures, right? Seizure and paresis.
Okay. So
And seizure makes sense, right? Because the cortex is involved in the frontal lobe. What is this structure here?
that's the falx.
Okay.
The anterior part of the falx cerebrum. So there is extensive calcification involving the anterior aspects of the falx.
Do you see calcification in the parts in 10-year-old?
No.
So
Okay,
you need to put it together, right? So other thing is that if you talk about calcification, this is not look like a calcification right here on the outside. This you can argue though this is calcification. What about this part here?
Okay.
And then you look at the second image, and that abnormality is going a little bit on the side here. So you have this hypodense area in the frontal lobe, 10-year-old, and then you have this hyperdense area along the falx and going around the convexity here. Can you put it together?
Could it be a bleed? A hyperdensity?
You're getting closer. We just talked about dense MCA, right?
Yes.
The thrombus looks
Hyperdense.
hyperdense. So what is this? This is the sinus thrombosis with venous. So this is what maybe you get. This is a first CT you see, right? And you see hypodense area, and then that's where the first suspicion starts, right? And then you can, what is the next step you do here?
An MRI.
You can get MRI. You can try to get the, if they can, there's no MRI, then you can do the CT venogram, right? Just look for the thrombus. The pediatric try to do MR if you can, So So sometimes it gets sort of like this, you know, and the cases are, and that's where you stop. When you tell them, oh, there's a venous infarct and there's a sinus thrombosis. That changed the whole management, right? Thinking about the 10-year-old, what is they're dealing with, right? They're dealing with venous infarct. So they're looking for the whole body, why the thrombus happened. So that's how the ischemia looks, right? The second is the intraparenchymal hemorrhage, which is the second common cause of a stroke. And I think we talked some of this yesterday. It's 10% of the cases. Remember, the common sites are the putamen, right? 60 to 65% cases, the thalamus, pons and cerebellum. The lobar hemorrhage is very 5 to 15% of the cases. And most of the time, there is a rounded elliptical area with the center in the basal ganglia or axonal capsule. That's how. So these are the typical sites for hypertensive hemorrhage. So if you see any of the sites and you ask the clinician patient is hypertension, those patients are hypertension, and you can assume that this is hypertensive bleeding because those are the common sites. These are where the most of the vasculatures are. So this is how it looks, right? Delay. There we go. Okay, so here this is the non-contrast CT brain, and you see the large hyperdense area. Remember the Hounsfield unit, right? And even the CT technologies, like at our places, CT technologies, even by the time you're calling them, they already know there's a bleed. Because they already call the ED doc, there's a bleed. You know, so they know. So even the other physicians also know how the bleed looks, right? So the most important part we are doing is looking for other things. So looking for the mass effect, that's very important. So there's a midline shift here, right? There's a compression of the ventricle, which they will not find out. You are the one who needs to call for that. It's a good size bleed, right? So this is how it looks, and surrounding hypodensity is edema. The second side, this is the thalamic bleed, and this is cerebellum. This is how it looks, the bleed on the non-contrast CT. So the differential diagnosis comes out. We talk about this. Most common cause is the trauma. Anytime you see the bleed, even if it's a typical side of the hypertensive bleed, still you say it's a trauma or not, right? And you rule out the trauma, then you look for hypertensive side, then you look for coagulopathy, then you think about all other things, underlying mass, vascular malformation, amyloid angiopathy. Those all vascularities comes later on the picture, right? So what is the comprehensive stroke image? Remember, I told you we have comprehensive stroke centers. So comprehensive stroke centers are there because they want to declot the artery faster, as fast they can, right? So the brain tissue doesn't get ischemia and don't die, because same in the heart, once the one cell of the myocardium is died, it's gone. Same in the brain is gone. That part you cannot regenerate, right? Other part might take over. That's why patient get paralysis, right? So that's why the time is brain. You know, you need to act faster. So they are looking for 4 P's: the pipes, which is all the arteries. Look for the perfusion. Look for how much supply is there and what is the penumbra. So I know you guys don't do the perfusion. We do perfusion routinely. So there was a big trend happened last few years. We did the perfusion in every single patient, CT perfusion in the stroke. They do non-contrast CT. The patients come in that window period. Do you know what is the window period? 6 hours for the anterior circulation and 8 hours for posterior circulation. And during that time, they can give TPA, right? So what is after that? There's somebody come with a stroke after 8 hours, right? And they said, oh, this person comes, most of the patients cannot tell when the stroke started, right? So it's early morning, 3 o'clock, it happened, they wake up and they cannot move their body, they come into the hospital. Already you missed the timing of the TPA, you know, they're coming at 10 o'clock, 12. So they come up with the American Stroke Association came up with the idea that we need to look at how much tissue is there and how much tissue is salvageable, you know. So can we prevent the tissue which we can prevent further damage? Because once it's there, you lose the function, right? So it's a whole cycle. Once that part of the middle cerebral keep throwing the emboli, that part of the brain is dead and the patient will be paralyzed for whole life. So that patient, once it gets paralyzed, if he survive from the stroke, then to take care of that person in the community, it's the estimated expense is crazy amount of expense to take care of that patient compared to you intervene early and try to unclot the artery, right? So that's why there is a big push for the all these aspects for the patients that intervene early, right? So we started doing perfusion. Then they come out with every patient getting the non-contrast CT brain, then get the CT perfusion and CT angiogram together. And we have this software for rapid software, and you get the, and I'm going to show you the images where you can see the how much is the mismatch. It's calculated by AI, and they decide whether to intervene or not, whether to take the patient to the NGO or not. And then there's a big paper published. There are a lot of paper published in different big centers, and this perfusion doesn't help. So now they are looking a little bit backward, but still we're doing the CT angiogram in every single patient and perfusion in the patients where they are confused whether to intervene or not. So for a few years we did the perfusion, and now we're doing perfusion only in the selected patients. So that's the parenchyma, right? So parenchyma. So on the diffusion and T2 images, you find out, right, whether the stroke is there or not. The vessels, so how to look at the vessels? By the angiogram, by the CT angiogram or MR angiogram. And the perfusion, we get all this map, right? Mean transient time, blur volume, blur flow. And so that's the penumbra. You put the diffusion images, which is already stroke. The area already got damage or in the process of damage. And you put the perfusion on the top, and you get combined perfusion and diffusion, and you can tell this is area already damaged, and the surrounding area is less blood supply. It will damage if you don't intervene. So that's called penumbra. So this is what you get, right? Diffusion. Do you know how early the diffusion can be positive on stroke patients? How much time it takes to get the diffusion with the frequency? No, how fast? Once you put the patient in the scanner, how fast you get the acquire the diffusion? 45 seconds. It's 45 seconds. Then technology takes time and then, but actually when you see it takes 45 seconds, you can tell there's a stroke or not. So we sometimes do hyperactive stroke imaging where the patient is not stable. They want to know there's a stroke or not. You can get the diffusion and tell, right? Just one sequence. So this is how fast it goes. It's easy always to get the diffusion. They come up with the idea that a lot of things can be bright, right? But then with the patient scan, you can also do the MRA. And if you do the MRA, sometimes you see there is a complete blockage. See, the internal carotid artery is completely blocked, and the cerebral artery, there is no flow at all. So sometimes you get the MRI, then always we do some kind of angiogram, MRA head or MRA neck, if you're getting MRI. And the same patient, if you put for the angiogram, sometimes you see the block. So this is the common carotid artery. This is the external carotid. You know all the branches? Yes? No? Yes? Okay, go ahead. What is this? You said yes, then I'm going to ask. If you said no, I will move forward.
So the first one on the bottom is the superior thyroidal artery.
Which one? Can you give me the...
This one
Okay,
is the superior thyroidal artery.
all right. Which one is this?
This one.
Yeah.
That's the occipital one.
No. See, here is the mandible, right? So this is something going in the front. See, when you say this one is occipital, I believe you, but not this. See, this is going in the back.
So
Which one is this?
this one is the facial.
All right. So after the lunch, I'm going to ask you this. Okay, because you said yes, but then you cannot answer. Okay, so let's keep going. Okay, because we are on time. So here's the internal carotid artery, right? And you don't see any flow there, right? So they go inside and put now there are different devices now. The neurointerventional guy says they do the declotting. They can put the TPA there. There is some devices come. They can suck out the clot, and then bring the clot down. And then if you see the follow-up imaging, you see the nice the recannulation, and you see all the circulation nicely. So that's the next step, right? That's why the time is brain. So the penumbra, right? We talk about the penumbra, the tissue at the wrist. So that's the salvageable. See, this is the tissue we're talking about. This is already damaged tissue. So this is what we do. So they put the patient in the scanner, CAT scan, and they need to inject contrast very fast. Do you guys have the injector? Yes. So they need to set up the time and inject very fast, and then it's pushed by the little bit push, more contrast, so it flow faster by a little bit normal saline, goes on the back. So it's little bit get more voluminous. So when you get the arterial phase, they put the cursor over there and they get the venous phase, like here is on supracerebral sinus, and then you get the images like this, and you get the map. So this is for CT perfusion. This is what we do. So you look at the map, and you need to see this peak that the artery is coming in and going down. If there is a waviness, then we think it's not a good, because there's a motion happen and it's not a good interpretation. The same is the venous, and then we get this localizer, right? So here's the middle cerebral artery, the localite, and here is the they put it here, the torcula or the supracerebral sinus, and from that you get this bolus arrival time, this is arterial phase, this is venous phase, and then you get this map. So we don't do anything, technology does everything. This is what we get on the images. So this sensitive perfusion right away. So you can see here, this patient has this is also color coded, so you don't need to do a lot of work, But it's not simple as I'm showing, right? There's also a lot of things involved. Like sometimes you see all the areas are abnormal. Sometimes you see its mismatch is not aligned, because once we started doing perfusion, we had a patient with the seizures, they also get the mismatch. We have a patient with the tumor, they also get the mismatch. Patient has a old stroke, they also get the mismatch. So all those things comes up, and we learn over the time that how to report this. But this is the area which is already damaged, and these are the bigger area which will be damaged, right? So both are the mismatch. The mismatch value comes out 65 ml, and we get the Tmax. So Tmax as a different graph comes out. Tmax, we used to use like 4 seconds. Now we're using the 6 seconds. They also have a graph for 8 seconds, but 6 seconds is something average they use, So it's the time for the contrast to come around in this area, right? So it's 111 ml, which is delayed here, and this area is damaged. So if they intervene, they can save this much volume of the brain. Right? That's what interpretation comes out. And so this is what we do, right? I show what we do, the Huntsville unit, we look at it, the artery, how we look at it, and the time to peak curve we get. And so these are the maps, cerebral blood volume. This is inside how it comes out, right? This is the blood volume, this is the blood flow map, and then this is mean transient time map. So you look at all three maps and decide how much tissue is at the risk. And the same thing they do on the MRI. You can do diffusion and the perfusion mismatch. Are we doing MR perfusion? No. Why? It's too much time. To get the MR perfusion imaging takes a long time. To put the patient in the magnet takes at least 15-20 minutes. You need to look at the screening, right? You cannot just put the patient in the magnet. You need to look at the whole screening procedure. There's a metal involved. There's all these things. The patient is unstable, cannot go inside. That takes at least 30 minutes. And the time is drained, so you don't have a time for that. So we don't do perfusion. But if some patients they do perfusion, if there's a time, then you can get the mismatch like that, and you can overlap. So remember, stroke imaging, the first is the CT is to rule out hemorrhage, right? Whether we give TPA or not, the CT perfusion we do it to intra-arterial TPA or declotting with the CT angiogram, so we know where is the block. And MR is usually useful for the patients with the TIA or differential diagnosis. For arteries, they also do the carotid Doppler once the patient get admitted. If they cannot do CT and patients are unstable, they can do carotid Doppler, because you get hemodynamic information which you cannot get with the CTA, and it is easy to do it and less cost. So remember, CT is way to go for the rule out acute hemorrhage. CT is why we do the CT, because it's 100% sensitive and specific for the hemorrhage, right? That's why CT is first. So the trauma, acute stroke, worst headache of the life, you do the CT, right? Okay, so couple cases, 63-year-old found down in the parking lot. Anybody? Oh, he needs to. No, he needs a mic. What's the diagnosis here? Acute, good. Acute subarachnoid hemorrhage, right? It is involving all the basilar systems. And what is this here? Yes. So that's important, right? Because there's a diffuse subarachnoid hemorrhage and hydrocephalus that's what we need to report and tell. The subarachnoid hemorrhage, they know that there is a bleed because they can, because of edema and hydrocephalus, patient can herniate faster, right? So they can intervene and decompress the brain. So what do you do next year? What is the most common cause of bleed? Okay, you need to find out there is no trauma, right? Again, no trauma, right? Which is sometimes challenging. See, it's found down in parking lot. This is real life scenario. This is what happens that you don't know. Yes. So they do CT angiogram if the patient is stable. The problem with the subarachnoid hemorrhage, you know what's the problem happen? They get the vasospasm. That is more dangerous, and those are the ones who kill them, you know. So they want to stabilize the patient first. Once the patient is stable, they can do angiogram. Right? So this is the angiogram, and you see angiogram. What do you see? Yes. So this one here is a maybe hypoplastic A1. This is A1 segment, right? Maybe hypoplastic or it's a spasm. You know, we cannot tell, but there's aneurysm, right? So once you see that, and the other thing is the aneurysm, they look for the boundaries. You know, it is irregular shape, and those are the ones which are the bleed. And if you find the more than one aneurysm, then it's challenging which one is the problem, right? So they always ask us which one you think is a problematic. And when you talk to neurointerventional people, they know the one which is irregular border, these are the ones which are bleeding. And you also look at the bleeding pattern. If it is diffuse like that, it is stop. But if you have the one side, like Sylvian Fisher, one side is involved, and the side is aneurysm, is irregular, then you can tell this is most likely. And they just go in and try to embolize that aneurysm instead of just going and do the angiogram, because that takes also a long time. And also there is always risk when they inject the dye in the artery. So that's the ACOM. Okay, so in summary, remember neuroradiology, we are the one, over there we are the one who make a first call. There's a bleed, no bleed. They're waiting for us. They identify imaging appearance on CT and MR, and we can tell it's a stroke, no stroke, right? Which block is there? Looking for what distribution, which is important, right? So do the CTA. You guys do CTA, right? For in every stroke patient? No, you don't do CT perfusion, but which is going away anyway. But CTA is the way to go, which is we can find out there's a large occlusion or not. So over there we call LVO, large vessel occlusion. And emergency room physician only wants to know whether there is LVO or not. If we call an angiogram, there's LVO, they just transfer the patient. All right. So this the second to break, or you want to continue? Continue? Okay, the next one is the case discussions. All right, case one. What's your name? Diana. Which year are you in? Third year. Okay. You guys have some Indian population here, right? I was searching online for, like, I'm from the west part of India, called Gujarat. There are like around 15 to 20,000 people here in Accra. Yes, because I was looking for, I'm vegetarian, I'm looking for vegetarian food, and my wife searched and we searched. I said, wow, there's so many people here. So I was surprised, so there are Indian population, you might get one of these here. Diana, right? Oh, Diana. Diana, did you listen to the lecture yesterday? All right. Then you can take this case. Okay, so here is the MRI. Let's start with this one. Do you see anything abnormal in this scan? So you're calling this abnormal or this abnormal? You give the, yeah. Okay, very good. Now this image is a lot of blurry, but that's what you get sometimes. You don't get the nice crispy images all the time. So what do you see there? Yes. Okay, so let me tell you, this part is normal. This is all you getting the partial volume. Do you see anything down in this area?
And also, yeah,
So when you talk about brainstem, this is midbrain, this is pons, and this is medulla, right?
yes,
So then you start here is the abnormal signal right here,
yes,
and it's going down. What is
yes,
this?
yes. It's the spinal cord.
This is spinal cord, right?
Yes,
So there's the abnormal signal in the optic nerve and in the spinal cord.
yes,
So does that give you some idea which direction we are leading? Did you listen the talk yesterday, right?
yes, yes, I did. Mm,
So we have optic nerve involved and we have spinal cord involved.
So maybe neuromyelitis optica.
Yes, very good. So that's the neuromyelitic optica, right?
Yes.
Very good. Okay, next case. If you listen, you remember. So this is the taste that who is paying attention.
A 7-year-old male is brought to the pediatric emergency department with rapid onset altered mental status, severe lethargy, and a new onset unsteady gait. His parents report that he has been highly irritable and developed a fever of 101.8 over the past 24 hours. Family history is unremarkable. On chat review, the child was evaluated at a local clinic 16 days ago for a self-limiting upper respiratory tract infection.
Okay, you ready? What's your name? Viola. Which year are you in? Third year. Good. Yeah.
Okay, so we have series of MRI images. The first is a T1, T2 flare. Then the second is a T1 with contrasts. So there are multiple areas of abnormal signal intensities, that is flare, hyper intense, seen in the pretrigonal region bilaterally and the frontal, bilateral frontal lobes within the deep white matter. There is also another one in the splenum of the corpus callosum.
Can you point me where you are? Okay. Okay. Where are this area? Okay.
You realize that these lesions have peripheral complete enhancements. So with this finding, take a depression of them.
Anything else?
Could also be a possible metastasis. Yes. Region has with suppression.
Okay, very good. So we go back. Okay, it's a 7-year-old, right? And no past history. And here is a hint, right? There was a self-limiting upper respiratory tract infection. So what is this? This is Adam. Very good. So only other diagnosis here possibility is this one, which is tough. Okay, acute hemorrhagic leukoencephalitis. And I have come across that case before, like hemorrhagic leukoencephalitis, and those are very rapidly progressing, and it's fatal within the 1 week, and it's hard to diagnose. Obviously going to make a diagnosis of ADEM, but these patients don't do good on clinically, and they always get the CSF and look for the other things, but that's the only difference in diagnosis with the other one. Okay, the next case. Here I already give you the hint. Next. Here's, I think they're giving it to you, Dela.
So a clinical triad of hearing loss, branch retinal artery occlusion.
What's the diagnosis?
Retinal artery occlusion.
You want to see the images, or you can make it? Images?
Images, please.
Okay. Here is the images.
Yes. So noted this sagittal T, a mid sagittal T1 weighted MRI of the brain, and noted along there are some hyper intense callosal lesions, multiple. I mean, we see them spanning across, so genial body and the splenum of the corpus callosum. In this case, I'm more inclined.
Let's go back to triad.
So a clinical triad of hearing loss, branch retinal artery occlusion, and encephalopathy. So
do you get this with MS? The patient only has a corpus callosum lesion. There are no lesions anywhere else.
Okay.
If you know, you know. If you don't know, you don't know. These are the classic case. So that's the Susak syndrome. So this one only way you know, because of the triad, the retinal artery occlusion and hearing loss, and then you have this history of patient has a hearing loss and some orbit issues, and then ophthalmologic, and they send the patient, and then you see this finding, and then you make a diagnosis, and you think it looks like MS because it's only in the corpus callosum. But remember, in the multiple sclerosis, you see lesions in corpus callosum, but you also see the lesions other parts also. I never have seen the cases that you only see in corpus callosum, right? You always have pericallosal white matter lesions. You also have a brainstem involved, you have temporal lobe involved, you have some subcortical lesions. So you see all these findings. If you have this one with your history of hearing loss and retinal artery, then you make this diagnosis, right? So it's a diagnosis of exclusion. That's why I ask you, can you make it? If you know, you know. Now you know. So This is the syndrome described by this American neurologist in long time back. I think they presented the case their ophthalmology conferences, and then they come up with the multiple cases and how it came into picture that these patients have a sensory neural hearing loss, on the bilateral, which is a little bit unique, right? Because most of the time the hearing loss in the young patients are conductive because you're looking for something in the middle ear happening. When you talk about sensory neural hearing loss in the young patients, you talk about all congenital things, which is then they already have, then they were born, right? So that's unique. And then patients go to because of the visual symptoms, they go to the ophthalmologist and they find out there's a retinal artery occlusion in the young patients. And they say, "Oh, why these patients are so young and they're hearing loss and this," and then got MRI, and that's how they invented this Susak syndrome. So it came out from that neurologist who invented. Okay, next one. So you all in the third year, that's how you rotating?
Final year.
Your final year?
He's 42 years old with history of HIV.
All right. With the HIV, remember we talked yesterday?
Yes.
So once the HIV things, what are the common things comes in your mind?
So
it depends on the count, right?
yes, so depending on the CD4 count.
Yes.
So I think less than 50.
Okay.
And then less than 200.
Okay. Anything else?
Capsulitis.
Okay.
So, and then other maybe opportunistic infections.
Yes. What are those?
So talk about also CMV.
The one with the cystic species.
Neurocystic necrosis.
And one more.
Cryptococcus.
Right? You need to remember that. That's good. So you remember, right, what we talked? So you should get this case.
Hopefully.
Here you go. Remember the history again. 42 years old with HIV.
So these are two MRI images. The first is an AZLT2. Okay, so it's the AZLT2 weighted MRI at the level of the lateral ventricles, and the second is AZLT1. Appears with contrast.
Yes.
Contrast post-contrast administration.
So let me interrupt you here. When you maybe you can answer, when you guys have a board exam here, does they get exam like in person like this, go the cases? So how it works, like you show the case and then examiner give the feedback or not right away, or they just wait and see what they are saying? So for example, he said this is T1 post-contrast. I said yes. Does the examiner respond back or not? Okay, so that's the tricky part. So you need to prepare yourself that before you say that you're not going to get feedback. The same over there in exam. Some good examiner will respond and some not. And some will respond such a way that because they want to let you keep going. They want, because you are not sure and they know that, but they want to keep talking, because once you stop talking, everything stops. Then they think that he doesn't know, right? So sorry to interrupt. Let's go. Go ahead. Good to know. You say same process. Yeah.
So the lateral ventricles appear to be dilated, mildly, and then there are these abnormal periventricular hyperintensities. find them. Um, okay. And
No.
post-contrast administration. I don't see.
We need to get the charges. Give you some time. Get the charges. Are you one of the residents too? Which year are you in? First year? Or you know all these technical aspects?
So extract that again. So these are two axial MRI images. The first is a T2 weighted image at the level of the lateral ventricles. The second is a T1 post-contrast image, also at the level of the lateral ventricles. There are fairly symmetrical periventricular T2 hyperintensities. They appear, which spares the subcortical U fibers. U fibers. On they do, there's no demonstrable enhancements of these areas post contrast administration. There is a suggestion of mild dilatation of the lateral ventricles, could be from brain atrophy in this 42-year-old. So with these findings, with the history of HIV, my differentials will include HIV.
Okay, very good. So that's HIV encephalitis, right? You know, we talked about the atrophy, cerebral atrophy, and young patients you see in the white matter, and that's very much it, right? We talked in detail yesterday. Okay, next case. You taking next one too?
70-year-old with question of TIA. So these are two axial MRI images. So they are both flare images, and they are the level of the lateral ventricles. So there are these T2 flare hyperintensities, periventricular hyperintensities. So they involve the deep ventricular white matter, and they are fairly symmetrical. And then there's also some of these in hyperintensities in the external capsule.
What? Oh, external capsule, okay.
And then, so it's on the left, but the capsule is on the left. And then there are also few ones, hyperintensities involving the subcortical white matter. Then they appear to be bilateral. $70. So we find this thinking of for the periventricular hyperintense, I'm thinking oh, but
Oh, yeah. So I think in exam it's important to know where to stop, right? Because I have seen that the candidates are confident in making diagnosis, but then they keep going. So when you keep going, that can create a problem, right? So, right? Because like I stop you here, but you start saying something else. Then I say, oh, why saying this now? You know, then they ask you, so why is now is everything changed? You know, so don't doubt yourself, right? So that's the chronic small vessel changes, right? Which is you typically see all the, everyday practice. So this is a pretty detailed slice about they publish about how the chronic small vessel changes happens. The leakage of fluid, and then all the precursors happen. But I think we will skip this part. But most important part, I'm going to. So sometimes they use this Fajika scale. Do you know about Fajika scale? Do you guys use that? Yes. We don't use. We use only for the trials. We just routinely we just say it's mild or moderate. It's not a common practice. Some of the trials going on in there, they want us to write the wordings, but everything is described instead of the scaling. Because scaling takes time. Instead of we just describe it's periventricular, subcortical, mild, moderate. So these are the grading, right? So nothing there. Then you see the pencil line and the little bit, and then this is the action into deep white matter. And so they come up with this differentiation between the hypertensive arteriosclerosis versus which cases you can call it's a cerebral amyloid angiopathy. And the big differentiation here is most of this in amyloid, it is in the lobar or superficial locations, and in the hypertensive one is usually the basal ganglia, deep white matter, and pons, and usually in front of parietal. Remember middle cerebral artery. They also talk about atrophy, which is you see in the both cases, so it's hard to tell. The other thing is these small areas of the bleed, right? The superficial siderosis, which is a key finding. You see multiple areas involved in the cortical, subcortical white matters, and not much in the basal ganglia. Then you think about amyloid angiopathy, and these cases are now diagnosed because of the gradient aqueous susceptibility weighted imaging. So that's the key point, which is useful. And most of the patients you have like mainly subcortical lesions than periventricular lesions. But I found the amyloid angiopathy is more easily find if you find all these superficial siderosis on the SWI or gradient. Okay, next case. Your time.
A 48-year-old female with severe chronic alcoholism is admitted for severe hyponatremia. Following rapid correction to severe hyponatremia, serum sodium of 102 units, milliequivalent per liter. And then following rapid correction to 124 over 18 hours, she develops acute dysarthria and spastic quadriparesis on hospital day 5.
You know the diagnosis? Somebody's saying from the back. All right, here is the image.
Okay, so this is axial T1 weighted, I think it's T2 flare MRI of the brain at the level of the pons. So we see this abnormal T2 flare hyperintensity involving the pons. And there are also some areas of hypointensity within this hyperintense region. The imaged temporal lobes are remarkable, and the partly imaged cerebellum is also remarkable. So based on the history given, I'll make an impression of pontine myellosis. I've forgotten. Osmotic pontine myellosis or something.
Central pontine myellosis, right? CPM. So I remember this one. The most important thing is knowing the center pons. The periphery of the pons is preserved. The first case we saw today, neurofibromatosis, there was expansal area and peripheral fibers were involved. So that's the one demarcation you can differentiate from the glioma, right? So because the diffuse involvement, that's the one you need to keep in mind. The second important part is what about stroke? This is a stroke?
Okay, that can be possible.
It's possible?
Yes.
So remember the stroke, whenever the stroke happens in the pons, it's usually the small branches, the pontine arteries get involved. So usually you see the like small areas get involved, like lenticular state. The diffuse involvement like this is very uncommon and very rarely. You hardly see like that. For that, you need to have a whole basal artery get thrombosed, which is very rare because you have so many other branches coming out right there, right? So this is like a Aunt Minnie case, right? With the history I gave it to you, you might not get the history. They might just show you the image, and they ask the question. So that's the osmotic malinolysis, right? The central point. Sometimes you see in the basal ganglia. So in the basal ganglia, you see the abnormal signal. Usually one side, unilateral. It is called extra pontine myelinolysis. And why it is more involvement of this high metabolic areas because of oligodendroglial cells. These are the most susceptible to osmotic stress. That's why you see in that area. Other important thing, there is no enhancement. Most of the cases, you don't see any enhancement. And you might see the follow-up and you just see the cystic damage area in the center of the pons, and patient might have that happen before sometime in the life. So that's what you see. So remember, T2 hyperintensity center pons, and sometimes extrapontine structures get involved, right? And periphery pons is preserved. Okay, next case.
A 38-year-old female presents to the neurology clinic with a history of severe atypical migraines with aura since her early 20s, alongside a recent onset of mild cognitive impairment. Her father died in his late 50s after suffering from premature vascular dementia and multiple recurrence.
See, so these cases I'm showing you with the detailed histories. Yesterday we did the case discussion without histories, just a small history, right? Headache, altered mental status. So when you get detailed histories, if your knowledge is good, you can make a diagnosis. You start thinking in the direction, right? Like you're a patient with HIV, you need to start thinking these are the possibilities, right? Or the patient with the hearing loss, and then you see the image. Okay, this is the diagnosis, right? So that's why I'm trying to show you another approach, which sometimes radiologists use to come up with the diagnosis. So if you are your neurologist or your referring physicians are good and give you good histories, or you can look it up with their history and try to read the images. It helps you a lot. Everything's there. You just need to combine together and make a diagnosis. Okay, so here is the images.
So these two MRI images. The first one is an ACL MRI at the level of the orbit as T2 flare, and the second one is also T2 flare at the level of the centrum semi-ovale. So noted T2 flare hyperintensities involving the temporal lobes bilaterally, as well as the pons, and also the centrum semi-ovale extending to the subcortical areas. The demonstrated orbits and flow voice appear unremarkable. So with the history and these findings, I'll make an impression of, I think, Gardner cell, cerebral autosomal dominant.
That's a hard one.
Subcortical, cerebral autosomic dominant, leukoencephalopathy, arteriopathy with subcortical infarct and leukoencephalopathy.
Okay.
Yes.
Okay, you said it.
Yeah.
So, what do you do next? Once you say, okay, there's a CADASIL, right? How do you diagnose? You suggested an imaging, right? There's a CADASIL.
It's come again. I didn't hear that.
Once you say there's a CADASIL, right? You make a diagnosis on imaging. What is the next step? Because you can only suggest, right, that
So
there is a cadence.
genetic testing.
What, say genetic testing? The patients cannot do. They cannot. Can you? Do you guys do genetic testing? Yes. What genetic testing they do?
Look like a biopsy.
Genetic testing is different than the biopsy. So they can do two things. They can do the gene chromosome 3. They can look it up, notochord, the notochord 3, and they can find out there is a mutation there or not. If you cannot do genetic testing, you can do the skin biopsy, right? And then find out there's, I think, eosinophilic area granular something happened, and it's a typical findings they can see and they can tell. The most important, the last case in this case, the chronic small vessel changes, and this one. So chronic small vessel changes you see every day, right? In the patients, these patients are usually younger. And when the chronic small vessel changes happen, usually in the frontal and parietal lobe, again in the middle cerebral artery distribution, you can have basal ganglia, infarct. These patients involve temporal lobe. So whenever you see the abnormality in the temporal lobe, you need to think about cadasses, you need to think about what else. So anytime white matter abnormality happens in the temple, you also think about demyelinating disease.
Okay.
Right. So white matter disease is so common. So that's how you try to differentiate out, right? This is small vessel. No, this is not a typical small vessel. There's temporal lobe is involved. There's a brainstem involved or not. Oh, this is cerebellum is involved. When you think about in aspect of demyelinating disease, right? If the confluent like this in a young patient with the history, you suggest them, and then you can tell them, oh, do the next step. But if you don't say cadasses, they don't know. They will stop over there. Okay, next one. Pediatrics. I don't remember. Some of the cases I don't remember even. We have too many cases, I will see the image and remember. Okay, 9-year-old with seizure and developmental delayed milestone.
Yes. 9-year-old male with seizures and delayed developmental milestones.
Diana, right?
Yes.
Here.
So these are two images. The first one is a T1, axial T1. And then the second one is also a T1 with contrast. So in the region of the bilaterally periventricular, there are these hyperintensities, periventricular hyperintensities. In the occipital lobes.
So remember yesterday I told, right, when you see the ventricles, body ventricles, 2/3, 1/3, frontal and parietal, right?
Yeah.
When you see the occipital horns, then you think about occipital lobe. Okay, so this is still frontal lobe and parietal lobe.
Okay. Okay. So periventricular hyperintensities, dominantly in the occipital horns.
So it's Aunt Minnie, right?
Then in the contrast.
Check up online.
In the contrast.
Yes.
They are not showing any enhancements. They appear hypo-intense in the contrast images.
What's the diagnosis? You see confluent area, right? Bilateral symmetrical. This is pretty unique, right?
Okay.
No enhancement. Somebody say peripheral enhancement. That's okay.
Okay.
Yes, if you know, you know. Right? These are the cases like this, Cystic syndrome. You know. Otherwise,
it has an appearance of a leukodystrophy.
Yes. Which kind? X-linked.
X-linked,
right?
yeah.
So this one X-linked, right? So X-linked, this is a lack of oxidation of this very long chain fatty acids, and that's why it's typically in the deep white matter happen in the posterior dominance, along the splenium and the parietal white matter, because of the very long chain fatty acid oxidation problem. And that's the most common, right? More common in the children and adults. Just a little bit later on, it comes up. And because of S-link, is the females are the carrier, right? You need to remember that. And happen in the young male, and most are diagnosed in the childhood, and sometimes it's the later young adults. And that's why it's most common adult onset leukodystrophy. So remember, I told you in the first case today that cases, this cases you need to diagnose. You know the case, and you know the imaging pattern, and you can make a diagnosis. So these are the stuff you need to know for sure. Okay, this one, no history because it's a typical. Pediatric patient.
So
Yes.
this is an axial T2 weighted. Is at the level of the lateral ventricles. So we see gross or diffuse cerebral volume loss, more pronounced on the frontal lobe.
So this is XLT2, right?
Yes, please. So on the spectroscopy,
Did you see anything abnormal here?
yeah, so there is T2 hyperintensities on the medial aspect of the lentiform nucleus bilaterally up, and then in the head of chordates.
So you think this is abnormal?
Okay, and the anterior limb of the internal capsule bilaterally.
Okay, so you see this area here from here, right and left. The both are bright signal, right?
Yes, please.
Your signal intensity is supposed to be iso intense, not bright like this. So it's confluent area, both sides, involving from the subcortical down all the way to periventricular white. Everything is involved, except cortex is preserved. Same thing, you go back down here, everything is involved. See, all the white matter is involved through and through. The only thing is left is your caudate nucleus is not involved. Your lentiform nucleus are intact. And the thalamus is debatable. Somebody might say there's a patchy signal in thalamus, right? So, and then compensated, there is a volume loss because everything is prominent CSF space. The subarachnoid space is prominent and the ventricles are dilated. And then you get this. So NAA peak, right? N-acetyl, what is NAA? Yes. So that's the neuronal marker, right? Which is highly elevated. So if I show you this and this together, what's the diagnosis? Somebody?
Canavan.
All right, Canavan. See, this case you need to know, right? Canavans. So this, do you guys see this here? You guys should know, right? That's what I thought. But so we see there's some time over there because we have Jewish community over there, right? And this is a frequency, and it's not common, but most is NAA, peak you see in the urine. They also see it in the urine. Okay, next one. This one is also pretty typical. See, I cannot end the white matter without showing leukodystrophy, right? Any volunteer? First year? He's passing it to you.
Okay, so two axial MRI images. The first one it's T1. And the second one is a T2. The first one is at the level of the orbits. The second one is at the level of the basal ganglia. Okay, so okay, so let me start with the second one. We see this, there's enlargement of the posterior horns of the lateral ventricles, and then the third ventricle as well. And then we see increased T2 signal involving the white matter. Okay.
What is this here?
Yes. So on the first image there, we see this bilateral oval hypointensities at the anterior aspect of the temporal lobes bilaterally. Well, there could be calcifications.
This big. So this surrounded big area like this.
Yeah.
In the symmetric, right?
Yeah.
And then there's a continued white matter here, right? On the T2. Also in the temporal area, see this area.
Yeah.
Right there. And there's also in the white matter here in the temporal is optical lobe, and the ventricles are dilated. This one you know.
Not too sure.
I know what cases I'm showing you, right? Yeah. So this one with the subcortical cyst, right? Megaencephalic leukoencephalopathy. So in India, there is this population, Agrawal community, that's the last name. And we commonly see in those people. I think there's some those are here too in Ghana, this community. And the megaencephalopathy, right? That's what in the first year of the life and with the development delay. But this is what you get, this typical appearance, Okay, so that's it for this one. You take a break. Yes. I think we're going to take a break. How? 10 minutes? 5 minutes? 10 minutes. 10 minutes break. Okay.
So we take a 10 minutes break and come back.
Your pages? Are you? What is what?
So what happened with the food? They can that place was.
Yes,
Oh, this is hot.
How do you solve this? Yeah. I'll mute it for you. Okay.
Okay, so we'll resume now. And I just want the residents online to note that we'll be calling on some of them to take the cases. Dr. Eboteria would mention the name, so just be alert. It might just be you. Thank you.
Here, let's do this.
They'll all be finished.
Trevor? Who's saying the name?
Yes, all of them online, but we'll still get participants.
Okay.
Okay, so we start.
Here. Okay, so I think this is another case review. So let's see who's taking the first case. Online or you're taking it? It's not coming up here.
Okay. So the history says symptoms started 3 days ago with difficulty of finding words, decreased consciousness, and vertical gaze palsy. No lateralization, no headache. So we have a non-contrast enhanced CT scan of the head and the level of the lateral ventricles. So noted noted two. So there are two hypodense lesions adjacent to the third ventricle. No. Okay, two hypodense lesions are adjacent to the lateral ventricles. No, it's a bit anterior to the. So I'll go for middle and medial anterior part of the thalamus.
Okay.
Yes, the medial anterior part of the thalamus. Apart from that, looking to see whether I'm seeing any other lesion around. So in the absence of that, thinking in a direction of an infarct, and with the location, I would presuppose we are dealing with an artery of Petron infarct.
Okay. That's good. But remember, we talked yesterday, right? When you have the thalamus involvement, you do your search pattern, right? Before you come to that diagnosis.
Okay.
Right. So what are the things can cause bilateral thalamic involvement? I saw a lot of cases yesterday, right? Of bilateral thalamus involvement.
Yes. So okay.
So what are the differential diagnoses when you see the bilateral thalamic involvement?
So I mean, infections, inflammatory. Okay. So
infarct, right? We talk about infarct. We talk about venous.
Okay, thrombosis.
Venous thrombosis, right? The second thing we talk about encephalitis.
Yes.
Right. So you need to start thinking, right? Make a diagnosis good, but start thinking, like say, okay, doesn't look like encephalitis because it's involved usually the bilateral thalami, usually symmetrical involvement. You can see there's some enlargement. Also involve not just the anteromedial part of the thalamus, it's involved other part of the thalamus because encephalitis doesn't know which area to get involved, right? So it will involve everything. Also, you need to think about this doesn't look like gliomas because it's just one particular area involved. It's not all the tracts are involved. Right? So you just keep going that direction. So, but your diagnosis is correct. This is a artery of perfusion infarct. And why they get that? Do you know? Why this typical abnormality? See here, it's the anterior medial part of the thalamus get involved. So here's the reason, right? Right here. So normally what happens, you have this basilar artery comes up and you are into posterior cerebral artery, right? And then you get all these small branches, which are the midbrain perforators, and then small branches, the thalamic perforator. When artery or percheron, what happens is just one branch comes up and then it supplies the both sides. You see right here, this is coming out on the right side and supplying on the both sides. That's why you get this abnormality. So it's not the both side, because to stroke happen on both sides is uncommon. When we talk about stroke, look at the symmetry, right? So bilateral thalamic stroke, uncommon, right? So if you talk about enteromedial involvement with arterial infarct, you need to have some congenital abnormality, otherwise it doesn't work, right? So that's why artery is coming out here and they're supplying both sides. That's why you get that abnormality. So yesterday somebody pointed out that, oh, this is arterial peritoneal infarct. This is classic appearance, enteromedial part. Remember yesterday somebody was mentioning, and I said I will show you the case tomorrow. So what do you see here? So this is a companion case, right? This is what typically you see. You see there's a little bit bright signal there, enteromedial aspect, and bright signal XCL-T2, and it is decreased on the flare, right? So this is what typically you see with the thalamic infarct. This is typical, right? See, you can get the infarct, but it's not like this on both sides. Those you get if you have this arterial percheron abnormality, right? So this is uncommon. This is common. Okay, next case.
With recurrent sudden onset of left upper and lower limb weakness and progressive drowsiness. So this is an unenhanced ASIA CT scan of the at the level of the midbrain, and it shows a focal area of the picture of the rest of the
Okay, what do you do next once you say there's a thrombosis?
how
Okay, after that,
so I can CT an angiogram.
okay, because sometimes you say busy artery thrombosis, but you need to prove yourself, right? So next step is the angiogram. So you can actually see that it is real or not. Okay, next case.
So these are three MRI, axial MRI images. The first one is a contrast enhanced T1.
Which one?
The first one. Okay. Oh, it's a flare. So I think the first one is a contrast enhanced T1. The middle one too is a contrast enhanced T1. No, the middle one is a flare. The last one too is a flare. Okay.
So if these two are the flare, remember we talked yesterday how difference the T1 and the flare. You cannot see the differentiation in the cortex and white matter. When you start seeing the differentiation, think about flare, right?
Yes, please.
We call this flare, then this one is also flare.
Okay. All right.
Other thing sometimes you useful, you try to look at the vessels, which is hard in this case, but sometimes you see the nasal mucosa and you're enhancing or not. But you need to go with these two are the flare, this is also flare.
So please, the first one, we confirm it's a flare, right? So the other, okay. So we see abnormal flare hyperintensities within the bilateral cerebellar hemispheres and in the subcortical regions of the occipital lobes bilaterally and also the temporal lobes more on the right, but also one on the left as well. Aside these flare hyperintensities, we don't do any other lesions. So with these findings, okay, please.
No, I don't think so.
Okay. Is there a history to this one?
History of hypertension.
Okay. Okay. So I make an impression of posterior reversible encephalopathy syndrome press.
Okay, very good. So even you think the press, you still remember, look at the diffusion and make sure it is not a restricted diffusion. And what do you do after this? You make a diagnostic press. Next thing, you look at the patient blood pressure, right? You always find out it is very high blood pressure. It happened during time, and then you are confirm your diagnosis. But then after you are done, then you do follow-up imaging because this will get resolved. This is just edema, right? So you do the follow-up imaging, and all these findings will go away in few weeks. Usually we get imaging after 8 weeks, and you see the changes, some residual things will be there, or it will be completely gone. So this is not a stroke, right? It's just a transient ischemia. And commonly you see in where?
In the occipital lobe.
Yeah, commonly parieto occipital area, you can see in cerebellum. Sometimes you have atypical press where you see the basal ganglia get involved. If you see the enhancement, those cases are worse. That takes long time to resolve. Commonly you see the pregnant patients, right? They with the high blood pressure, preeclampsia, or with the history of the chemotherapy in ovarian cancer. Those are the cases we like to see more. Sometimes it's a hard time to differentiate between hemolytic uremic syndrome versus this press, which they can only tell clinically. We cannot tell on imaging. So these are the other cases where you see the press is involving more area like in the basal ganglia, but always bilateral confluent, and this is the distribution, right? Parieto occipital area. And sometimes you might not see bilateral, sometimes it's like asymmetric, like this involved. And look at the diffusion, and there will be no restricted diffusion, right? You just see the bright signal on DWR. And you do the follow-up, the same patient, you do the follow-up and see all these areas are completely resolved. Right? So that's why follow-up imaging is useful to confirm the diagnosis that, those areas were temporary. There is no any ischemia or infarct happen in those areas. Okay, next case. No, nobody online. After that, online. Online so for me is like where they are,
Okay. So these are 3 MRI images. The first one is okay. So the second one is an ADC, and the first one is a DWI, and the last image is a T2 at the level of the cerebellum. So noted in the right aspect of the medulla is high DWI signal. On the companion ADC, there is reduced signal, or the suggestion of reduced ADC signal in the right hemi-medulla. On the T2, there is increased signal. There's hyperintensity in this area. The rest of the demonstrated cerebellar hemispheres appear remarkable on the DWI, ADC, and the T2. So with this findings, I'll make a diagnosis of, I'm thinking of an infarction in this area. So like a lateral medullary syndrome.
Do you see something else?
Okay, so on the T2, within the flow void of the right vertebral artery, it appears larger than the left vertebral artery, and there is a hyperintensity within it, which on the ADC, it has high ADC signal. So I'll make I think there's a thrombus within the right vertebral artery, and that is what is causing the infarction of the right hemi-medulla.
Okay, very good. So there's one, this image is enough to make a diagnosis, right? There's a thrombus and there's an infarct. But this patient has a dissection of the right vertebral artery. So remember, when you're looking at the cases of stroke, the first of all, the medulla is the area where you can miss the stroke. When you look at the diffusion, go down and scroll, everybody missed the medulla infarct for sure. All the fellows missed in the training. And the most important, look at the flow void. And when you make the medullary area is infarct, anything in posterior circulation, look for the dissection in the young patients, and you will see the case where there is dissection. And so here is the MRI. You can see there's a intimal flap in the right vertebral artery. So dissection is one of the cause if you see the stroke in the younger patient. Okay, next one. Now online, right?
Okay. Two more here.
Oh, two more here, then online. Okay. I don't know how many cases I have, but.
Okay. 30-year-old with frequent TIs, seizures, and depression. This is an
You know the diagnosis, right? We had this case.
Yeah, I think it's a CADASIL.
Yes.
Because of the temporal.
So the important point here is you see the diffusion. You need to make sure these areas are not bright on diffusion. And it can also, you can sometimes see in the pons also, right? Okay, so you're awake. That's the CADASIL, right? The whole name here, cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. This is young and middle-aged, right? In absence of the vascular risk factor, that's the most important point. Other things we discussed. Okay, the next one. So this is not a front. This is so. I think I'll define this as a periventricular white matter area. Because when you come here, this is a part of the putamen comes here, right? When you scroll, so it's definitely you need to say the periventricular area, instead of the frontal lobe.
Ventricular white matter region on the left. It causes significant mass effects on the adjacent left lateral ventricle. On the second image, on the left cerebral peduncle, there is an abnormal signal intensity that is T2 hyperintense. Please, that is.
No, this is what we have. So what's the diagnosis?
It's possible we get infarcts.
Okay. So if this is an infarct, what is this here? Where is this located?
In the left cerebral peduncle.
Okay, so what is that called? If you know, you know. Somebody is mumbling, I can hear. So that is a Wallerian degeneration, right? So Wallerian degeneration, right? It happens, it's important to know this, because this entity only we can diagnose with MRI, and most of the patient has a stroke, and it's usually beginning the 1 week of damage, and it damage continue for 6 months. It continue keep damage. It's irreversible damage, and so remember that myelin peak we talked yesterday. That get breakdown, and then it leads to gliosis, and then atrophy happens. So it's typical the cerebral corticospinal tract get involved, and you get in the midbrain, and that's what you get, bright signal, and then you try to look for where the stroke, and you will find the area of the stroke. Okay, next case. Now somebody online, right? Needs to say the name.
Dr. Farida.
Okay, good morning. So this is an axial DWI image of the zoomed in of the head, zoomed into the posterior fossa, and it shows an abnormal high intensity or high signal within the right aspect of the cerebellum. I would like to see the accompanying ADC if there's one.
So is this the cerebellum, the arrow pointing out? What is this structure?
The pons.
Okay, so we go down. Remember, the pons is always in front of the fourth ventricle. So what is the brainstem structure after the pons if you go inferiorly?
Medulla.
Okay, so this is medulla.
Okay.
Okay, so it's the abnormal signal is not in the cerebellum, right? It's in the medulla. That makes a difference, right?
Yeah.
We talked anatomy yesterday. So we have abnormal signal in the medulla. So can you say something about that? Anything coming out of your mind that why there's abnormal signal there?
So an abnormal high signal in the medulla, it could be vascular in origin, so that it's an infection, and then it could also be it could be demyelination, as seen in multiple sclerosis, like we discussed yesterday. It could also be high signal in medulla. If this patient was an alcoholic, it could be Wernicke's encephalopathy. And then it could also be a glioma.
In Wernicke's encephalopathy, I don't think so medulla is involved, right? You get in the thalami, abnormal signal, you can get the mammillothalamic tract involved because limbic system is involved. You know, we talked about limbic system yesterday. The mammillary body get atrophy, you get some signal around the gray matter, periaqueductal gray matter. That's what you get with the alcoholic encephalopathy.
Okay.
So not typically medulla is involved. But I like other things you say, the infarct, you also say demyelination. You need to go further down, right? Also, you need to think about neoplastic like glioma.
Yes,
So,
I gave the differential of glioma as well.
Yeah. So the glioma usually like to give expansal signal, and it's not the typical site for glioma. And this lesion is not expansal. The infarct, we can only tell if there's a diffusion. If I give you, then you can tell. So there's a possibility. The MS, you can tell if there are other lesions, right? So there's one more thing to think when you involve this area. So this is a part of the area of the medulla is called what? So there are different parts of the medulla, right? There's a pyramid and there is an olive. So this one is the
pyramid.
So there is another condition called, anybody? From this triangle, any idea what is this triangle is? The triangle is going from red nucleus to medulla to dentate nucleus. So whenever you see the abnormality here, the next eye should be go on the red nucleus and dentate nucleus, because sometimes you might see abnormality all three together. So this is that Gillian molar triangle, right? So that's the dentate nucleus, the rubro and olivary pathway get involved. So red nucleus, then so you get the same side, right? Ipsilateral red nucleus and ipsilateral medulla get involved, and another side of the dentate nucleus get involved. So this is called what?
I'm not sure what this is.
So this is hypertrophic olivary degeneration.
Okay.
Right, and the most common you see this signal. There is always etiology higher up, like you see the case of the hemorrhage somewhere like in the cerebellum or in the region of the midbrain, or there may be ischemia, trauma, surgery, you know, any of these things you see in this triangle area. And there's a compensatory mechanism, so that's why you see the bright signal there. It is important to identify that, because then you don't go in the pathway of the demyelination or tumor or stroke, right? So you don't see all those findings. You don't see bright signal. You don't see expansal lesion. So this is a compensatory case. Like you see this, there's the abnormality, big area here, and the same patient has the abnormality on the medulla. And you try to look at the red nucleus, and red nucleus usually like this. You might see the one side is the dark signal, other side maybe a little bit faint, right? So you see the abnormality in this triangle, and that's called hypertrophic olivary degeneration. And you will see this case. You try to look at in the patients with the stroke, you know, in the midbrain stroke.
Dr. Pariado. Dr. Pariado.
Oh, so this is not transferring.
Dr. Pariado.
Good afternoon.
Good afternoon. It's all you 12?
Okay.
No, not yet.
So these are two axial CT scans of the brain. And the first, I think, is in the The first is at the level of the temporal lobes, and then the second is at the level of the lateral ventricles. So noted in the region of the right right temporal lobe. These multifocal regions of hyperdensities with surrounding minimal edema or surrounding minimal hypodensity suggestive of edema. And then on the second image, there's this fairly defined lesion in the frontal parietal region with some lobulated margins. Some areas also appear, the posterior aspect of this lesion appears to have some hypodensities. Are there more images to this?
So this one is putamen. Remember we talked about the bleed? This is typical part of the basal ganglia. You know, the hypertensive is, I saw the image on the stroke. And this is correct. This is involved in the temporal parietal occipital area because this is the occipital lobe here. Other thing is that there's a mass effect, right? So that's important to note. There's a mass effect in midline shift. This ventricle is compressed. So these are basically there's a hemorrhages, right? There's a hemorrhage in the putamen. There is a hemorrhage into the temporal and occipital lobe with surrounding edema. And there's significant midline shift here. You can draw the midline and hard to see even the ventricle part. And there may be herniation, right? So those things are important to mention because the patients might not go far from these findings. You know, they might need to intervene to stabilize because remember there's a part comes here, which is hard to see here, which is uncus, right? The uncus herniation can happen. And that's why you don't see the cisterns here. Look at the hard to see any basilar cisterns here. Midbrain is hard to make it up here. So those are the important things. But you ask for the next images, and this is what we have next. So this is same patient.
At the level of the lateral ventricles, and this is a GRE sequence, and noted in the frontal parietal region, in the right cerebral hemisphere is a fairly defined area of blooming artifact in multiple areas similar but smaller areas of similar presentation. That's the blooming artifacts. There are some areas within the sulci with this blooming artifact.
So where is this located? This blue
bleeding in the sulci.
So it's called subarachnoid.
Subarachnoid, yes, please.
Yeah. So this is subarachnoid hemorrhage, and this one is intraparenchymal hemorrhage, right?
Yes, please.
And then you have a lot of small areas which are subcortical hemosiderin products, right? So you have a intraparenchymal hemorrhage, you have subarachnoid hemorrhage, and multiple lobar hemorrhages, right? So what is the diagnosis? You have multiple areas of bleed with subarachnoid hemorrhage.
Please, I didn't hear that, but can you come again? Hello?
Yeah. So if you have multiple
what was the question?
Can you hear us?
Hello. Yes, please. I was asking the question.
Yeah.
You said something I couldn't hear.
Oh, I'm saying there's a multiple lobar hemorrhages, and then you see the subarachnoid hemorrhages, and there are multiple this subcortical small hemorrhages. So when you
So
have multiple hemorrhages, what is the diagnosis you think about? Remember, the number one cause of the bleed is what?
an angiopathy.
Yes. What I could not hear. What's the first part you said?
An angiopathy.
Yeah. What kind of angiopathy?
Or multiple cavernous malformation.
All right. So in the multiple cavernous malformation, you will not see subarachnoid
With a
bleed.
differential. Pardon?
Yes. What else?
With a differential of cavernous malformation.
Okay, so I'm saying in the cavernous malformation, you will not see subarachnoid hemorrhages or tiny, the big lobar hemorrhages. You might see one area. You can have multiple cavernous malformation, but when you go to CT, that doesn't support, right, this big bleed here. So there's multiple hemorrhages, multiple cavernomas in differential diagnosis, but this is not the case of multiple cavernoma.
Okay, so that would be I'll stick with the angiopathy.
Okay.
An amyloid and angiopathy.
Very good. Okay, that's what I was looking for. So remember when we talked about in the stroke cases, then if you have multiple hemorrhages, the amyloid is in the bottom on the list. You rule out everything else, and this SWI helps a lot because subarachnoid hemorrhage or multiple different hemorrhages in the brain. But when you see SWI, then you can make a diagnosis that this is amyloid, and you can stop there. Okay, thank you. Very good. I think that should be the last case. Any questions? No question. Anybody online has a question? He's in charge of online.
Thank you very much, Prof. Thank you, everyone online and those present. At this point, we'll break for lunch and then come back in an hour's time. Thank you.
Guess as a lover, I have a ways to go. When some you'll understand if you take my hand, then we can dance. To something radio, listen to the radio. What's on? Listen to the radio. Let's spend the night together. Baby, don't go. They sing it on the radio.
Kentucky, on a cool autumn evening, Billy lay in love with Mary Ann. She was a rich judge's daughter. He was the son of a miner, but that night their love was more than they could stand. The judge said to his daughter, that son of that coal miner is someone you'd do well to leave alone. She knew her dad so well, she knew she couldn't tell, but the truth was bound to show before too long. Their love had started growing on its own. You can't outrun the long arm of, no, you can't outrun the long arm of the law. Billy placed his hand on Mary, and he felt the baby moving, kissed her and said, I'll see you when I can. The judge had made a promise When he caught up with Billy, it sent him far away from Mary Ann. The whole town knew he'd do it. Too many times he had proved it to at least 100 men behind the wall. He'd smile behind that frown, and when he brought that gavel down, he called himself the long arm of the law. And he'd set his mind on seeing Billy fall. In a hot, humid mine shack, a midwife pulled the sheet back and placed a cool, damp towel on Mary Ann. Billy's eyes were wide with wonder from the spell he was under when she placed the newborn baby in his hands. He didn't hear the siren, just the baby crying. That miracle of love is all he saw. When the door came crashing down and Billy turned around, he felt the heart and soul inside him fall. He stood face to face with the long arm of the law. You can't outrun the long arm of the law. No, you can't outrun the long arm of the law. You can hide out for a while, he says with a smile, but you can't outrun the long arm of the law. Seemed like everybody down in Cumberland, Kentucky came out that day to see poor Billy's trial. The court was called to order. There sat the judge's daughter. She looked so proud holding Billy's child. When they brought Billy to him, the judge just looked right through him as he held that holy Bible in his hand. And he smiled at his grandson, then his eyes cut back to Billy, said, I think this time the law will understand. Son, I sentence you to life with Mary Ann. You can't outrun the long arm of the law. No, you can't outrun the long arm of the law. He said to Billy with a smile, I know you hid out for a while, but you can't outrun the long arm of the law. No, you can't outrun the long arm of the law.
Coffee black, cigarette. Start this day like all the rest. First thing every morning that I do is start missing you. Some broken hearts never mend. Some memories never end. Some tears will never dry. My love for you will never die. yellow rose. You asked me out, and to your surprise and to mine, I said I'd go. I thought it so romantic, and I found you sweet and bold. Though we'd only met, I still said yes to a single yellow rose. And for years to come, you were the one to sleep with me at night, to laugh and talk and share my thoughts and hold me when I cried. And on every rare occasion, and for no good reason too, a big bouquet or a single yellow rose was sent from you. Yellow roses, the color of sunshine. You loved me at one time. Why did you have to go? Yellow roses, are you sending your new love? My bright yellow rosebuds, I still love you so. I never see a yellow rose that I don't think of you. It's still my favorite flower, though the yellows turn to blue. The day you left, my teardrops fell upon your farewell note. You said goodbye like you said hello, with a single yellow rose. Yellow roses, the color of sunshine. You loved me at one time. Why did you have to go? Yellow roses, are you sending your new love? My bright yellow rosebuds, oh, I still love you so. Yellow roses, the color of sunshine. You loved me at one time. Why did you have to go? Yellow roses, are you sending your new love? My bright yellow rosebuds, I still love you so.
Our love is unconditional. We knew it from the start. I see it in your eyes. You can feel it from my heart. From here on after, let's stay the way we are right now and share all the love and laughter that a lifetime will allow. I cross my heart and promise to give all I've got to give to make all your dreams come true. In all the world, you'll never find a love as true as mine. As long as there's a breath in me, I'll make yours just as sweet. As we look into the future, it's as far as we can see. So let's make each tomorrow be the best that it can be. I cross my heart and promise to give all I've got to give to make all your dreams come true. In all the world, you'll never find a love as true as mine. And if along the way we find a day it starts to storm, you've got the promise of my love to keep you in all the world. You'll never find a love as true as mine. A love as true as mine. Look at this face, I know the years are showing. Look at this life, I still don't know where it's going. I don't know much, but I know I love you. And that may be all I need to know.
Look at these eyes, they've never seen what matters. Look at these dreams, so big and so better.
I don't know much, but I know I love you. And that may be all I need to know. So many questions still left unanswered. So much I've never broken through.
And when I feel you near me, sometimes I see so clearly the only truth I've ever known is me and you.
Look at this man, so blessed with inspiration. Look at his soul, still searching for salvation. I don't know much, but I know I love you. And that may be all I need to know. be all there is to know. Last night I had a crazy dream. Wish was granted just for me. It could be for anything. I didn't ask for money or a mansion in Malibu. I simply wished for one more day with you. One more day, one more time, one more sunset, maybe I'd be satisfied. But then again, I know what it would do. Leave me wishing still for one more day with you. One more day. First thing I do is pray for time to grow. I'd unplug the telephone, keep the TV off. I'd hold you every second, say a million I love yous. That's what I do with one more day with you. One more day, one more time, one more sunset, maybe I'd be satisfied. But then again, I know what it would do. Leave me wishing still for one more day with you. One more day, one more time, one more sunset, maybe I'd be satisfied. But then again, I know what it would do. Leave me wishing still for one more day. Leave me wishing still for one more day. Leave me wishing still for one more day. every now and then, softest breath upon my skin, I feel you come back again. And it's like you haven't been gone a moment from my side, like the tears were never cried, like the hands of time holding you and me. And with all my heart I'm sure we're closer than we ever were. I don't have to hear or see, I've got all proof I need. There are more than angels watching over me. I believe, oh, I believe. Now when you die, your life goes on. It doesn't end here when you're gone. Every soul is filled with light. It never ends if I'm right. Our love can't even reach across eternity. I believe, oh, I believe. Forever you're a part of me, forever in the heart of me. I will hold you even longer if I can. Oh, the people who don't see the most see that I believe in ghosts. If that makes me crazy, then I am, 'cause I believe. Every now and then, softest breath upon my skin, I feel you come back again. And I believe.
Got a picture of you I carry in my heart. Close my eyes to see it when the world gets dark. Got a memory of you I carry in my soul. I wrap it close around me when the nights get cold. If you ask me how I'm doing, I'd say just fine. But the truth is, baby, if you could read my mind, not a day goes by that I don't think of you. After all this time, you're still with me, it's true. Somehow you remain locked so deep inside. Baby, baby, oh baby, not a day goes
this, baby. If you could read my mind, not a day goes by that I don't think of you. After all this time, you're still with me, it's true. Somehow you remain locked so deep inside. Baby, baby, oh baby, not a day goes by. Minutes turn to hours, and the hours to days. Seems it's been forever that I felt this way. Not a day goes by that I don't think of you. After all this time, you're still with me, it's true. Oh, somehow you remain locked so deep inside. Baby, baby, oh baby, not a day goes by that I don't think of you. He finally gave in to his friend's girlfriend when she said there's someone you should meet. At a crowded restaurant way across town, he waited impatiently. When she walked in, their eyes met, and they both stared. And right there and then, everyone else disappeared. But one boy, one girl, two hearts beating wildly. To put it mildly, it was love at first sight. He smiled, she smiled. They knew right away. This was the day they'd waited for all their lives. For a moment, the whole world revolved around one boy and one girl. In no time at all, they were standing there in the front of a little church, among their friends and family, repeating those sacred words. Preacher said, "Son, kiss your bride," and he raised her veil. Like the night they met, time just stood still. For one boy, one girl, two hearts beating wildly. To put it mildly, it was love at first sight. He smiled, she smiled, and they knew right away. This passed away, lying there in bed and listening to his newborn baby cry. He makes a pot of coffee and splashes water on his face. His wife gives him a kiss and says it's gonna be okay. It won't be like this for long. One day we'll look back laughing at the week we brought her home. This phase is gonna fly by, so baby just hold on. It won't be like this for long. 4 years later, about 4:30, she's crawling in their bed. And when he drops her off at preschool, she's clinging to his leg. The teacher peels her off for him. He says, what can I do? She says, now don't you worry, this'll only last a week or two. It won't be like this for long. One day soon you'll drop her off and she won't even know you're gone. This phase is gonna fly by if you can just hold on. It won't be like this for long. Someday soon she'll be a teenager, and at times he'll think she hates him. Then he'll walk her down the aisle and raise her veil. But right now she's up and crying, and the truth is that he don't mind as he kisses her goodnight and she says her praise. He lays down there beside her till her eyes are finally closed, and just watching her it breaks his heart, 'cause he already knows it won't be like this for long. One day soon that little girl is gonna be all grown up and gone, and this phase is gonna fly by, so he's trying to hold on, 'cause there won't be like this for long. It won't be like this for long.
Lay down, my dear brother, lay down and take your rest. I wanna lay your head upon your Savior's breast. I love you, Jesus loves you best. I bid you good night, good night, good night. I bid you good night, good night, good night. Lay down, my dear brother, lay down and take your rest. I wanna lay your head upon your Savior's breast. I love you, but Jesus loves you best. I bid you good night, good night, good night, good night. I bid you good night, good night, good night. One of these mornings bright and early and soon, good night, good night, good night. Now they're picking up the spirit to the shore beyond. Good night, good night, good night. Go walking in the me. Good night. John the Wise said I saw a sign. Good night. Lord send a fire, not a flood next time. Good night. Tell me, Father, on that wonderful boat. Good night. She really loaded down, getting water to flow. Good night. Not leave for the beast at the ending of the world. Good night. Eat all the children that would not be good. Good night. I remember right well. I remember right well. Good night. I went walking to Jerusalem just like John. Good night. Good night. Oh, good night. Lay down, my dear brother. Lay down and take your rest. I wanna lay your head upon your Savior's breast. I love you, but Jesus loves you best. I bid you good night. Good night. Good night. Good night. Good night. I bid you good night. Good night. Good night. Good night.
All our tears have reached the sea. Part of you will live in me, way down deep inside my heart. The days keep coming without fail. Is gonna find your sail. That's where your journey starts. You'll find better love, strong as it ever was, deep as a river runs, warm as the morning sun. Please remember me. Just like the waves down by the shore, we're gonna keep on coming back for more, 'cause we don't ever wanna stop. Out in this brave new world you see, oh, the valleys and the peaks, I can see you on the top. You'll find better love, strong as it ever was, deep as a river runs, warm as the morning sun. Please remember me. Remember me when you're out walking, when snow falls high outside your door, late at night when you're not sleeping, she put him out. Like the burning end of a midnight cigarette, she broke his heart. He spent his whole life trying to forget. We watched him drink his pain away, a little at a time, but he never could get drunk enough to get her off his mind until the night he put that bottle to his head and pulled the trigger, and finally drank away her memory. Life is short, but this time it was bigger than the strength he had to get up off his knees. We found him with his face down in the pillow, with a note that said, "I'll love her till I die." And when we buried him beneath the willow, the angel sang a whiskey lullaby. La 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 la. La 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 la.
The rumors flew, but nobody knew how much she blamed herself for years and years. She tried to hide the whiskey on her breath. She finally drank her pain away, a little at a time, but she never could get drunk enough to get him off her mind until the night she put that bottle to her head and pulled the trigger, and finally drank away his memory. Life is short, but this time it was bigger than the strength she had to get up off her knees. We found her with her face down in the pillow, clinging to his picture for dear life. We laid her next to him beneath the willow, while the angel sang a whiskey lullaby. La 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 la. He can't remember the times that he thought, does my daddy love me? Probably not. That didn't stop him from wishing that he did. Didn't keep him from wanting or worshiping him. He guesses he saw him out once a year. He can still feel the way he felt standing
standing in tears, stretching his arms out as far as they'd go, and whispering, Dad, I want you to know I love you this much, and I'm waiting on you to make up your mind. Do you love me too? However long it takes, I'm never giving up, no matter what. I love you this much. He grew to hate him for what he had done, 'cause what kind of father could do that to his son? He said, damn your daddy, the day that he died. The man didn't blink, but the little boy cried. I love you this much, and I'm waiting on you to make up your mind. Do you love me too? However long it takes, I'm never giving up, no matter what. I love you this much. Halfway through the service, while the choir sang a hymn, he looked up above the preacher and he sat and stared at him. He said, forgive me, Father, when he realized that he hadn't been unloved or alone all his life. His arms were stretched out as far as they'd go, nailed to the cross for the whole world to know. I love you this much, and I'm waiting on you to make up your mind. Do you love me too? However long it takes, I'm never giving up, no matter what. I love you this much.
I'm back on the road. Sometimes I don't know. It's hard to make good sense of it all. When I have to roam, my mind's back at home, thinking of you there all alone. But we're doing well, somehow I can tell. I really don't know, it's something I feel. 'Cause we've been making it strong, each day right along. Though we both hate being alone, it's gotta be magic, we're still in tune. There's good love in midnight or noon. It's gotta be magic,
keep saying goodbye and keep on wondering why, though we both know it just has to be. Oh, but honey, the road can get to be such a load. You're all that helps me make it, I know. It's gotta be magic, we're still in tune. There's good love in midnight or noon. It's gotta be magic, I know it's true, 'cause it's still working for me and you.
Love is like a butterfly, as soft and gentle as a sigh. The multicolored moods of love are like its satin wings. Love makes your heart feel strange inside. It flutters like soft wings in flight. Love is like a butterfly, a rare and gentle thing. I feel it when you're with me. It happens when you kiss me. That rare and gentle feeling that I feel inside. Your touch is soft and gentle. Your kiss is warm and tender. Whenever I am with you, I think of butterflies. Love is like a butterfly. The multicolored moods of love are like its satin wings. Love makes your heart feel strange inside. It flutters like soft wings in flight. Love is like a butterfly, a rare and gentle thing. Your laughter brings me sunshine. Every day is springtime. And I am only happy when you are by my side. How precious is this love we share. How very precious, sweet and rare. Together we belong like daffodils and butterflies. Love is like a butterfly, as soft and gentle as a sigh. The multicolored moods of love are like its satin wings. Love makes your heart feel strange inside. It flutters like soft wings in flight. Love is like a butterfly, a rare and gentle thing. Love is like a butterfly, a rare and gentle
Adios, amigo.
Hello?
Adios, my friend.
Hello?
The road we have traveled has come to
Please let's start settling down as we begin the last session in a minute or two. Thank you.
and it's you who she longs for. It's you she will choose. Adios, compadre. What must be, must be. Remember to name one muchacho for me. I ride to the Rio, where my life I will spend. Adios, amigo. Adios, my friend.
Everyone, welcome back from lunch. I hope we all had a good lunch. We are ready for the next session, which is the afternoon session. In this session, we'll look at brain tumors and multiparametric imaging, as well as cellular and supracellular imaging. Promodi is here. He's ready to take us through. So let's all pay attention and try not to sleep. Let's stay awake and then get involved as much as possible. Thank you. Prof, please with me.
Okay. Communicate understanding of advanced neuroimaging methods. Okay, so for brain tumors, we use the CAT scan, MRI, basic and advanced technique. When we talk about advanced technique, we talk about DTI and fMRI. Now, these are done in the centers where they do it, not in all the centers they do it routinely. And I think we talked yesterday, some of the pre-operative planning, some places they use it. The nuclear imaging is useful in some of the cases when we talk about radiation necrosis and the tumor. And angiography is useful for preoperative embolization of some of the tumors, and sometimes also for diagnosis. All right, so see the brain tumors coming from brain and is covering, right? So this is the incident. I don't know the incidence here, but this is overall incidence in North America, and obviously less cases in the children's. The majority are 80% are supratentorial, right? And the 40% of those are mats. So this is the classification. Now, WHO classification, the brain tumor can be classified in different way, but this broadly classified in this way: the neuroepithelial tumor, which is 50% of the cases, and those are the astrocytomas, which are coming from the neurons itself. The ependymoma I mentioned this morning is coming from ependymal, the lining of the ventricle. The medulloblastoma, oligodendroglioma. These are the neuroepithelials. Meningioma is coming from the coverings. Then we have pituitary tumors, acoustic schwannoma, CNS lymphoma, spinal tumors, and germ cell tumors. So these are the incidents. And if you know appearance of all these common lesions, that entail majority of the brain tumors. So when we talk about the classification, these are the glial and the non-glial. So when we talk about glial tumors, these are the ones which are coming out from the itself, from the oligodendrocyte, then it's oligodendroglioma. It is coming from the glial cells, then particularly the astrocytomas, and there's a big classification inside, right, to differentiate what kind of glial neoplasm we are dealing with. When we talk about the metastasis, these are the common, right? Again, the most common cancer is lung, right? Doesn't matter it's male or female. So that's what most common see. The second one is the breast cancer, right, in female. So that's what we see. Then we see the mets from all these different cancers, right? The melanoma, renal, colon cancers. The mets from colon cancers are there, but it's not common because by the time patient has a colon cancer by stage 3B, they are already peritoneal seeding is there. And then if it is present that late, then it will lead to colon cancer mets. So it's not common. But most of the time you see the lung, breast, and melanoma. You know, those three are the common. So here is some age group. The astrocytoma. Remember, there's you can see all the age groups starting from the birth all the way to the old age. Talking about choroplexus papilloma, teratoma, all these germ cell tumors, germinoma, teratoma, that in the pediatric age group. The craniopharyngioma is here, but also there's a second peak happens somewhere down here at the 40 to around the 50, 45 or 50. But the majority craniopharyngioma you see in the pediatric age. Medulloblastoma, ependymoma, this again in pediatrics. So in the middle-aged and older population, you start seeing all these common tumors, the acoustic schwannoma, pituitary adenoma, oligodendroglioma can go until the age of 50. So this is just a rough idea. You know, you get the idea that you don't mention teratoma in the older age group population, you know, because they come early. So the reason this table is here to just give you some rough idea. You know, craniopharyngioma, yes, it can happen in adult, but that's not your first diagnosis, right? So the common intraaxial tumors in adults. So if you talk about supratentorial or infratentorial, it's MAT. Doesn't matter. It's adult population, it's MAT. Infratentorial after MAT, the second one, we had a case yesterday, right? We saw some cases. Always think about MAT. The second thing you talk about hemangioblastoma. Those are the common. The common things are the common. If you say that thing, you will never be wrong. The supratentorial mass, then you talk about gliomas, right? So we have different gliomas. Now, glioma is, they used to call it glioblastoma multiforme. See, I put it here. Nowadays, they change the histological classification. They just call it glioblastoma. They decided not to use multiforme. That's fine. You know, there's always change, right? We have upgrade in the computer. Similar, there's upgrade. So there's the glioblastoma. So the glioblastoma is, there are different grading. The WHO classification, right? World Health Organization do this classification. So everybody are same, and they follow the guideline to treat the tumors. Like in the For example, head and neck cancers, they use all the lymphadenopathy classification like levels. The levels are universal. Okay, you are reporting in India, reporting here, reporting US, it's the same classification, right? They try to do standardized so people get treated the same way. So the glioma are 25%, and they are the low-grade glioma, the grade 1. Then you're talking about anaplastic astrocytoma and glioblastoma. So anaplastic astrocytoma is grade 3, and glioblastoma is grade 4. The oligodendroglioma usually grade 2, and it can go higher up. You know, 3, very rarely 4, but usually 2 or 3. So this is directly from the their classification, the glioma WHO grading. So you can see the grading here. So pay attention to grade 4. See the glioblastoma, the higher the grade, worse prognosis, right? You know, glioblastoma patient doesn't survive more than 6 months to 2 years or 3 years. You know, that's their prognosis. So it's important to find out that what grade they are. The similar gliosarcoma follow the same pathway in gliomatosis cerebri. Do you know what is gliomatosis cerebri? Yes? No? Okay, so when you high grade glioma involved in more than one lobe, right? When you see the glioblastoma usually in the one lobe, but if you see the same tumor or high grade tumor in the more than one lobe, you have a frontal lobe, then temporal lobe, both are involved, then it's a gliomatosis cerebri. The gliosarcoma is just histopathologically different. It's more malignant tumor like glioblastoma. It's very hard to differentiate on imaging. You cannot tell it's a glioblastoma or gliosarcoma. You can at least tell it's high-grade glioma. So the anaplastic astrocytoma is grade 3. So they treat these tumors like glioblastoma, you know, because these tumors are also very malignant, right? And it can grow, and the problem with astrocytoma is like glioblastoma is a well-defined tumor. The astrocytoma are infiltrated. So they're hard to define the boundaries. That's why the neurosurgeons go in and they want to resect the tumor. They cannot separate out normal tissues from the this tumor because it's infiltrating. So they always use the marker. Remember, they put the fiducial markers when they operate the patients because they use a navigation system and see the distance from the cortex or from that marker, how far deep they want to go in, right? So because when they open up, they cannot see what is tumor and what is not. We are seeing inside, right? On surface, everything looks the same. So the anaplastic astrocytoma is like that. The grade 1s, the pilocytic astrocytoma, and we saw this morning, right? Subependymal giant cell astrocytoma. The pilocytic astrocytoma is how it looks on MR. Does anybody know? Cystic lesion, pretty good. And what is the common location? Posterior fossa, more precise. So okay, so you can see in the cerebellum or you can see in the pons, right? Those are the two common locations, and those are the grade 1, right? The problem with the pilocytic astrocytoma are they are the top location, so they usually cannot biopsy. You don't want to biopsy that cerebellum or pons. The other problem is common in the pediatric population, so they will be reliable on imaging. They will see the classic appearance, you make a diagnosis, and they will start radiating the patients. You know, they don't want to do more damage because they are slow growing. Right? So that's why imaging play a big role, and everything else is here in between, right? Grade 2, the genitocytoma. These are hard to make the diagnosis on the just based upon imaging and say this is grade 2. We can say high grade, we can say low grade. In between is stuff. So oligodendroglioma are here in the grade 2, and when it can go to the grade 3. The thymoma are 3 kinds. There is no grade 4. Remember which one doesn't have a grade 4. You know, all these tumors doesn't have a grade 4. So subependymoma, we saw this morning, right? The giant cell astrocytoma, they are usually smaller. Very tiny lesions, smaller size, around 1 centimeter, and usually happen along the lateral ventricle. That's a common size. The ependymoma can get bigger as a grade 2, and then it can convert into malignancy. So that's why there's a grade 3. Choroplexus, all these choroplexus things are all in the pediatrics. Papilloma, this atypical. Some can happen in the adults, so slow growing, and then it convert into there. But majority you see in the pediatric population. And others, these tumors are there on the list, but we cannot differentiate on imaging. It's pretty hard. Okay, so we started the case. So everybody stay awake.
Okay. So this is an axial T1 contrast enhanced CT MRI of the brain at the level of the lateral ventricles. So noted in the left parietal lobe of the brain is it's an oval enhancing, heterogeneously enhancing lesion with a dural tail. Now this lesion appears extraaxial. It causes a level of cortical buckling. Also noted is a CSF. Also noted is a CSF cleft around the lesion, which gave me the indication that it was an extraaxial lesion. So putting the findings together of an oval rapidly enhancing heterogeneous lesion with a dural tail and a CSF cleft causing cortical buckling of the adjacent cortical brain tissue, I'll make an initial diagnosis of a meningioma.
Did you say there was a midline slip? Yes. Okay, so that's important thing to say, right?
Yes.
They know there's a tumor. The other thing, the surrounding area, this is edema, right? See, there's a hypointense area. So there's the edema, which you can see better with the flare. So they are not interested in this stuff. They're interested in whether there's a midline there or not, whether you're calling edema or not. And do you know why? Why it's important to talk about midline slip and edema?
It pertains to the prognosis for the patient, and
Not-
also the pressure, the pressure in the brain. So when you can have the sulfur sign herniation.
Yes. So meningioma you will find commonly the tumor which cause mass effect and compressing the brain. Those are the ones they will go after. Otherwise, they will not touch. So
Right.
that's the indication for surgeons to go in and intervene. So most of the cases, the tumors are there, but the most important demarcation is is causing midline slip and mass effect. If you call the surgeons will operate this one and take it out. The dural tail you mentioned about that, right? This will tell you it's extraaxial or not. And this is what you get, right? You get this calcification, which is another diagnostic criteria which help you to make a diagnosis. Sometimes it happens, and I think I saw the case yesterday where you have dural enhancement. It is a thick nodular enhancement in the cases of the pachymeningeal enhancement, right? And on those cases, you need to make sure we are not dealing with the dural metastasis, right? Sometimes you can have that. The other thing you see is the hyperostosis of the bone, right? Because these things are chronic, it is there since long time. So here the meningioma are the most common primary brain tumors, right? Which everybody will see on the CAT scan and MRI. The 50 to 30% of the primary brain tumor, 33% are incidental. Remember this. It's a lot of cases you find incidental brain tumors, right? And so those are the ones they're going to not operate, they're just going to follow. Only 10 to 15% are symptomatic. right? So it's here more in the female because they have a, you know why it is more common in the female population than male? Because they have receptors, they have estrogen and progesterone receptors. That's one of the reasons they are more common in the female. And it's less, the children's is not common, right? So basically there's a more common primary brain tumor for the adult population. So meningioma I need to know in the depth because you see commonly, so see this is the uh, locations, right, where you see, so 20% you see convexity. So when you look at meningioma, to know where it is located. So if it is at the convexity, say it is a convexity meningioma, they likes to know that. If it is at the parasagittal area, say parasagittal, you know why? Because there is a dural sinus there. They likes to know how much compression is causing it, or it is invading the sinus. Those are the things they look for. If it is olfactory groove, tell them it is olfactory groove because their approach for the treatment completely changed, right? If it is paracellular, important to know because there are all the important structures in the cavernous sinus. With sphenoid ridge is totally different tumors because the approach to the pterion, right? They need to cut out to the pterion, and that also changed. Posterior fossa, they likes to know because those are they hardly going to operate, right? Because there are big structures there unless there is a mass effect. And some other tumors like 2% are optic, happen in the optic seat. There could be intraventricular meningioma, spinal lesion meningioma. You can see 1% are extracranial, which are very rare. These are only diagnosis by the histological, you know, which is very hard to find. Intraspinal, yeah, we're going to look at some images of intraspinal. And look at the 60% are multiple at autopsy. That means we could not find on imaging, and still they are. So they are that common, and not all are symptomatic. So most of the patients, like over the age of 60, they found in 16% of the cases in autopsy. They are all parasagittal and multiple. This is a growth rate. See, it's growing very slowly, right? Independent of the tumor volume and age. This is the annual growth rate. So where it is come from? So meningioma is coming from meninges, right? But which part of the meninges? Meninges coming for arachnoid cap cells in the granule. Remember we talked about arachnoid granulation this morning with the CSF episode. It is coming out from there. Some of these things, like where it's coming from, it comes out on usually in the board exam with the multiple choice. You know, meningioma coming from where? Then you know it's coming from arachnoid cap cells. And these are the invagination, right? When the meninges are forming, it goes the deep down in, and that's where the pia and arachnoid precursors happen. So that's where it comes from. And any of these layers, you know, so any layers will go down, like intracranially, all the cells, innermost layer of the meninges goes deep down and make a peat like that. The meningioma can come from there, and that's why sometimes you see the intradiploid meningioma, or sometimes with the spinal meningioma. You know, that's just the layer go deep down, and the cap cells was there, and that got proliferation, and you get the meningioma. So these are the receptors. See, in the 2/3 of the patients, there were receptors. The estrogen receptors are less common, progesterones are more common. And you see this one, meningioma increasing the size in pregnancy. And I had a case where the patient was pregnant from headache center, and patient imaging many years back, and patient has a severe headache, and the meningioma really got bigger. And I remember I read that time somewhere that you get bigger in the pregnancy. And I actually saw the case, and they have to actually operate the patient because of it was in the cerebellum, and there was a lot of edema. So they have to take the tumor out. And the reason it increased because she was pregnant. She got pregnant, and it was stable size, but during pregnancy, because of receptor, remember there are progesterone receptors. So pregnant patients come with the headache, and there's a non-meningioma, look for there's a bleed inside, or look for it's bigger inside. You will see once a while, you know, case like that. Also, meningioma is associated with breast cancer. The breast cancer patients, sometimes you see there is a focal area of enhancement, and you think it's a mat or meningioma. Those cases, you just do the follow-up study, and you find out whether it is getting bigger or not. That's the only way you can tell. So there are some other risk factors like radiation, right? So somebody say meningioma happened, why it happened? And you find out in the history the childhood person had some kind of radiation. They used to give the radiation of lymphoma and leukemia. And after 20 years, they found, oh, there is a tumor in the meninges because they radiated. So sometimes you see the association. Sometime in the familial non-NF2, right, you can see the meningioma. So these are some other factors you need to keep in the mind. So here, so what kind of meningioma is this? Now you need to tell me, right, where it is located. Convexity meningioma, right? And you see the here little calcification, right? And you also see the dural tail. There's a small dural tail here. Again, is this causing mass effect? Yes. So this one surgeon's favorite, right? They like to see this one. Okay, we have other one, right? So where is this located? So this one are the convexity, right? And then the one in the medially here. Yeah, so that's the parasagittal, right? Yes, and that's where the you look for the venous sinuses. So look at here, the convexity one here. So which sinus comes here? Superior sagittal sinus. Now, when surgeons operate the superior sagittal meningioma, it's pretty risky for them because some of those they need to move the superior sagittal sinus on the side, and there's always chance of more complications. So these are the one they will not try to intervene unless it's sometimes you see the big mass and they want to intervene. And I've seen the cases that it turned out not good. After they operated those tumors and there's still bleed going on, and patient get the venous infarcts, and they cannot remove the whole tumor because once they go in, they find out that some of the parts are very adherent to the sinuses, and they cannot take it out. So here, 5% of the cases, multiple meningioma, you can see in the neurofibromatosis, right? Sometimes you see the with the other lesions too. Meningioma comes out like there's a pituitary lesions there in the pituitary area. You can see, oh, this is a pituitary adenoma, or actually turn out to be meningioma. So this is the what is the case? Oh, mycos. Okay. So this one is WHO grade 2. So meningioma is a 3 grading. The grade 1, what's the treatment for grade 1? The grade 1, if there's a mass effect, midline slip edema, they will take it out. Complete take it out, you are done, right? So that's the treatment. The grade 2, and there's the other one, grade 3. So grade 3, they treat like a malignant tumor, like a GBM, right? It's very aggressive. There are very few cases. Grade 2 are the problematic ones. So currently we are doing trial. It's now how many years? So almost 15 years. No, it is, my son is 18, so it is 18 years. I am on the trial for meningioma. And we're doing trial for grade 2. And we are doing the trial, now it's on phase 3. The trial is going on the WHO grade 2, whether we radiate after surgery or we just watch it. And we the outcome came out, some of the outcome is out, and whatever comes out, we publish. So the problem with the WHO grade 2 meningiomas are, compared to grade 1, some of the features, when they do the biopsy and they take out the tumor, they found that the nuclear cytoplasm is not like typical normal. And the pathologist can make a diagnosis that this is atypical. Right? So sometimes it's hard to know from the imaging that this is WHO grade 1 or 2. And those patients, we are doing trial that by just doing the stereotactic focal radiation or the whole brain radiation, which one works better. right? So that's a grade 2. So grade 2, they're going to follow up to see they want to go in or not. And this is what you see in the grade 2. So there's a big mass here, right, which is cystic and solid. And you see the cystic component is not enhancing, the solid component is enhancing, and there is a highly cellular tumor. And it almost looks like a meningio, but it doesn't make sense to have this cyst here, right? So sometimes there could be cyst also, and there's edema here. So they operated, and this turned out to be WHO grade 2. So then they need to follow up. The grade 1, they take it out, they don't follow up. They're done over there. So this is another case, atypical. Can we remove here this hard for me to?
Oh, you want to move that? Okay.
Yeah, it just you have to. There you go. Can you do OK here? This will go away. There. Thank you. Okay, so here is the tumor in the cerebellum, right? This tumor is located where the transverse sinus is, so here, right here along the tentorium. And look at the signal intensity inside. So it's extra-axial tumor, but signal intensity is not like you see typical with the meningioma, is diffuse enhancing. Instead of we see the heterogeneous enhancement, there is a hemorrhage inside, and all the necrosis inside. And also this tumor is along the transverse sinus, right? So you don't see this is the MRV images, and you don't see the transverse sinus. So when you're reporting this, most important to report the features inside, and also important to mention about this is invading the transverse sinus. Right, so and definitely you talk about edema and mass effect on the fourth ventricle. So this is the atypical meningioma, which is a grade 2. So after that, we move to pineal region tumors. So we remember the anatomy, right? The pineal gland is right here, right? We talked yesterday. What is this area? Fornix, good. All right, so we go further down. Which vessel is this? Yes. Okay, somebody wants to take a case?
So this Miss Sajata T2 weighted image of the brain. So it's been zoomed into the brainstem. Okay. So in the region of the pineal gland, being pointed to by the black arrow, straight arrow, there is a fairly defined expansion, or yes, heterogeneous intensity within the pineal gland, and it's expanded. There are areas of low, high intensities and areas of increased intensity within the pineal gland. Add arrows down into it.
Is normal, abnormal?
It looks abnormal.
Okay. What you want to do about it?
Do we have other images?
What do you like?
It's a CT scan.
Yeah, I don't know what is next. Okay, so we'll find out. This is what you get.
All right, so another MRI. Okay, so the image is a coronal T2 weighted MRI of the brain at the level of the lateral ventricles. The image level B is easier T2 weighted MRI at the level of the
what is
third
this
ventricle.
structure?
No moving. It's a calcium pointer.
Why this is not? Mine is frozen online. Oh, here, now I can see. What is that?
So that would be the phonics.
Phonics.
Yes.
And what are these structures here? These rounded areas?
So those are vessels.
Yes, what vessels?
Internal cerebral vein.
Yes, good. Let's see what we can- You see something here?
CT.
Yes.
So it's a non-enhanced image, and it
Yes.
shows hyperdensities of calcific attenuation in the region of the pineal gland.
Okay.
Okay.
What do you see here?
So this is an easier T2 weighted MRI image of the brain at the level of the ventricle. So the calcific density is showing hyperintensity here. It's also peripherally located around the pineal gland. And then there is central hyperintensity.
Okay.
T2 hyperintensity.
So what is it? So it's a pineal cyst, right?
Yes, please.
Okay, so this bright on T2, what sequence is this?
So there's a flare image.
Okay. So how is the signal there?
It's hypointense. It suppresses on flare.
So it is not completely CSF signal, right?
Okay, yes. So
I like to see dark like this here, right?
So it doesn't suppress completely.
So see, I show you the normal. So this area is normal. This pituitary, this is how it normally looks. When you blown down, this is how it looks. Now you come to here, and this is abnormal. You see the difference between normal and abnormal? And there's a calcification, right?
Yes.
So what do you do if you see the pineal cyst, which is not following the CSF signal?
Some contrast. So this one, C1 hypointense. We can do a DWI.
We're asking too much.
We have contrast.
The DWI maybe show the bright signal, for the fluid, but that's pretty much it, I think that all things are lying here because the signal is not dark like CSF. So this is your pineocytoma. Right? So the problem with the pineal cyst, let's say you see the cyst, the pineal cyst, which is commonly seen, and so you like to see the signal of the CSF like here, because it follows the CSF signal in the pineal cyst. So do you follow pineal cyst if you see on imaging? Yes, no? No? Yes? You never encounter pineal cyst? Then you need to encounter. Because pineal cyst is not uncommon. You will see pineal cyst on an adult population. So most of the pineal cysts are benign, so the criteria is more than 1 centimeter, and the wall thickness, you look at the wall, It's 1 to 2 millimeter, more than 2 millimeter thickness, or there's nodularity. Those are the ones they follow. Otherwise, there's no guideline to follow. The one which causing the, remember I showed the anatomy here. So this is the final grade. What is this area? This is the
tectum
tactile plate, right? So tactile plate, it can cause mass effect and block the aqueduct and cause hydrocephalus. So one which cause mass effect and hydrocephalus, those are the ones are important. The one which I mentioned the criteria more than 1 centimeter, there is a wall thickness more than 2 millimeter, there's a nodularity, or something doesn't follow the typical CSF signal. Those are the ones they like to follow, right? And the pediatric population is completely abnormal. If you see pineal cysts in pediatric population, they are very conservative. They will follow that, which you're not supposed to see there. So this is pineocytoma, and there's a low grade. That's the most common pineal tumor, right? The mean age is 40. The low grade, so it's just stay stable. That's why there is no much talk about. You miss it, nobody will find out because it's often stable for years. Nothing happens unless it's caused the mass effect and there's a hydrocephalus happen. So most common, see hyperintense on T2, and the cyst common, it may hemorrhage, and that's where the problem happen, right? The enhancement can happen. The problem is here, benign pineal cyst, indistinguishable cells. So you cannot distinguish between the pineal cyst versus the pineocytoma unless you see the imaging I show you, right? So that's why the lesions which are bigger or there is 2 millimeter or more wall thickness, those are the one you follow. Okay, next one. We're looking at the pineal tumor, right?
The axial is the first one is a T1 unenhanced image. The second one is a T2, and the third one is a T1 post-contrast image. So noted in the region of the pineal gland is a heterogeneous mass that has iso-intense areas and hypo-intense areas, as shown by the arrow. This hypo-intense area on the T2 is hyper-intense, showing that it's it likely has some cystic areas. In addition, on the contrast-enhanced image, it shows variable enhancements with very enhancing portions of the mass. I'm not appreciating. Okay, I'm looking for calcification. There are no calcifications noted in this image, and the mass is causing. It's not really causing any significant hydrocephalus. Okay. So with these findings, I'll make an impression of the pineoblastoma, pineocytoma.
Pineoblastoma is a big diagnosis.
Okay.
This is not do good. So I cannot tell, what, it's a pineal tumor. The important thing here is causing mass effect on the third ventricle. That's why you see the frontal lobes are dilated. The other thing is this is not a cystic tumor. This is solid, right? We just saw the cyst, how the cyst looks. Yeah. This is just solid, right? And maybe you can say there's a cyst, a cystic and solid tumor, right? There's a irregular enhancement. So this is a pineal region tumor. Now, can you tell what it is? Most of the time you cannot. So there's a grade 1, we talk about pineocytoma. The grade 2 is this spinal parenchymal of indeterminate differentiation. The report just said this is worrisome for pineal tumor, most likely pineal parenchymal tumor. Just leave it there because you cannot make a diagnosis. They can go to grade 2 or grade 3. And this one, they will take it out because they are more aggressive than pineocytoma, right? Because they will get bigger. It can cause it will go to CSF, can cause the spread. You cannot differentiate. There's a new entity came out like papillary tumor pineal region. You cannot differentiate that on imaging. The surgeons like to know there's a solid lesion there. There's a hydro. They will go in and they will resect out. Okay, so this third one, anyone?
Okay, so we have 4 images. The first one is an axial CT scan, unenhanced at the level of the lateral ventricles. The second is a T2 weighted axial MRI, also at the level of the atria of the lateral ventricles. The last 2 images, the first one is a contrast enhanced T1 sagittal MRI, mid sagittal MRI. Then the last image is it's also the T. Still contrast is a flare. Okay, it looks like a T2 flare or contrast enhanced T1.
Okay, what would it be the last? I cannot.
Come again.
Can you repeat the last sentence?
I said the last image.
Yes.
It also looks like a contrast enhanced T1.
So this is a pre-contrast, right? And this is a post-contrast.
Okay.
Yeah.
Okay, that's fine.
So what do you see?
Okay, so there's an irregular, ill-defined hyperdense lesion in the location of the pineal gland. It appears to infiltrate the medial aspect of the, should I say, the posterior aspect of the thalami. On there is the third ventricle is a bit prominent, as well as the other ventricles. On the MRI, on T2 is hyper intense. On T1 is heterogeneous. It has some hypo intense as well as hyper intense areas, and it shows enhancing areas on the sagittal T1 contrast enhanced. Noted in the region of the fourth ventricle, it appears to there is a lesion within the fourth ventricle. It seems it extends into the fourth ventricle. So with these findings, I'll make an impression of mesopineal cell tumor. This will be a high grade and differential of pineal metastasis.
Okay, pretty good. So remember this CT, the tumors is how it is. It is
hyperdense.
Hyperdense. So there are very few tumors which are hyperdense, right? When you think about hyperdense, they are highly cellular tumors like lymphoma. You know, we saw the lymphoma yesterday. So that's the first sign, right? Giving you this, you're talking about the highly cellular tumors, and then it's irregular shape, right? It's irregular, and there is a causing the obstruction. The tactile plate is completely effaced here, and then in this case, you see already the other lesions down going in the fourth ventricle. So this is high grade. So this one most likely is a penioblastoma, you know, because it's going to seeding, right? And you have all the features which suggest you have high grade tumors. So these are the grade 4. And look at the age. That's important, less than 20, right? The prognosis is very, very poor. And yesterday I saw the case. Remember somebody trilateral retinoblastoma? When you have a bilateral retinoblastoma and your final tumor is called trilateral retinoblastoma, you know, that's one of the popular questions they like to ask. Because they like to ask, there's about the pediatric patients with the white eye, leukocoria, and we find the retinoblastoma. Where else you look for? And then they show the image with the final tumor, you know, so that's the trilateral retinoblastoma. So it's another case where you see the typical area, right? Again, this is isointensive of the brain. There's an enhancement and some calcification. There's a hydrocephalus. And So these are the cases like they likes to go in and take it out. And so this one you cannot tell, right, what it is. You just say it most likely pineal parenchymal tumor, and you give a call to surgeon, there's hydrocephalus, they will go in and take it out because it's not going to be pineocytoma. It's going to be either grade 2 to grade 4, you know, one of the direction, but they will operate because there's obstruction. Everybody know what is this, right? Pituitary adenoma. You see this, right? You don't see pinal cyst, but you see this. So this is typical appearance, right? The pituitary, what's the size criteria? Okay, 1 centimeter. And do you see microadenoma? Yes. And why this one? What presentation this comes with compared to microadenoma? What? Blindness. Why? Yes. So why the microadenoma doesn't come with the blindness? Smaller size, right? So why are we finding out microadenoma more earlier than macroadenoma? What? Yes. So the microadenoma are more functional, right? So the patient commonly has some endocrine function problem. Usually the female patient you might see, or there's a prolactin elevation, or you can see hypogonadism. And so there's a hormonal changes, so they will image early. So you'll find out early. These tumors are non-functioning, so it keep growing and it's bigger, and then patient has a blindness or there's a visual symptoms, then they present. So it's already bigger that time. So that's why this one is bigger, then you find out. You know this one, right? What is it called? What is this appearance called? Ice cream. Yeah, don't forget ice cream. So that's typical, right? And most important thing here, sometimes you might misinterpret the meningioma as a schwannoma. The most important is, remember, the epicenter is here and is going out. When you have is a dural tail and little bit going in, then those are the meningioma. We'll see some tumor cases tomorrow, I think, that we find out. But this is, we talk about this adult with the unilateral sensory hearing loss, and that's what you look for. Okay, somebody wants to take this one? 59-year-old with the headache.
59-year-old woman with X.
Yes.
So this is a non-contrast axial CT scan of the head. So in the region of the left frontal lobe, there are right, sorry. Right frontal lobe.
Right there.
Multiple areas of hyper density, which have look like they have a specific attenuation, and then they look so the frontal lobe, there are hyperintensities that have a calcific attenuation. And also surrounding it, this hyperintensity is likely edema. So I'm not seeing any mass effect. Yes, there's no significant mass effect. So did you have any other imaging like contrast or? Okay.
No.
Okay, so
they did just to rule out bleed.
So with these findings, I'll give an impression of oligodendroma.
Yes. So this is typical, right? You don't see this much calcification in frontal lobe. Oligodendroglioma likes to calcify. So this is the grade 2. Do you see oligodendroglioma here? I'm sure you do. Yes. So if you attend their conference in your neuro-oncology when they decide the treatment, Remember, surgeons find out the tumor, they resect the tumor, but it doesn't stop there, right? They need to find out the grade and do the treatment according to that. So they look for this mutation IDH and 1p19q deletion. That's only polygo, and depending upon that, they decide whether it will respond to chemo or not. So that's important. The mutation they look for in the tumors. So it can happen, and most commonly you see like frontal lobe area get involved. The male patient is more 50 to 60 card, and this is classic case, right? You see the calcification. None of the tumors will show this much calcification except oligodendroglioma, and it is 70 to 90% of the cases. Sometimes you see the cystic changes and minimal enhancement. The problem with the oligodendroglioma is the recurrence. They like to recur. You know what is this, right? Everybody knows this. Glioblastoma, right? That's the most common primary adult brain tumor. Right? Okay, so when we talk about astrocytomas, right, we talk about all this: pilocytic anaplastic astrocytoma, GBM/anaplastic astrocytoma are the big group which comes here. These are some other astrocytomas like fibillary astrocytoma. That goes here, but the majority of astrocytomas here. That's why we found those commonly. So this case, it's 18-year-old with the seizures. What do you see here? This is a flare sequence. Anybody wants to take this online now? Oh, here, see. Yes.
At the level of the ovary.
You guys love sentence in your Yes. Yes, you are correct.
Okay. So, noted is an abnormal signal in the right frontal lobe. It is in the deep white matter extending to the subcortical region. It does not cause any effect.
No, it doesn't enhance on contrast. But that's very much it. Things become easy, right? Because we are in tumor section. When you are not in tumor section, I show the images, then you start doing other stuff, right? Let's say the difference here. But you see, 18-year-old with the seizure is a big thing, right?
Yes.
You don't supposed to see anything in 18-year-old. It's a pristine brain like the left side. So what is this?
So my thought is astrocytoma.
Okay, so I will not say astrocytoma right away, okay, because that's a histological diagnosis. So you say glial neoplasm, most likely, if it is not enhancing, right, then it's a low grade, right, and that's where you stop. But it's hard to make the diagnosis as anaplastic astrocytoma unless they do the biopsy, right? So these are the low grade astrocytoma, right? This is how it looks like, and usually they don't enhance, and over the years it just slowly progress, And the difficulty is these tumors is hard to treat because what to do here? They cannot resect. It's hard to differentiate out. They can do biopsy for diagnosis. They can radiate. That's maximum what they can do and try to control the seizures. What we have here?
So okay, so T1 with contrast. So with these findings, so these lesions do not have significant histogenic, and that's not cause any mass effects.
Okay, so there's edema here.
Oh, okay.
There's a lesion here, right? This is left parietal. There's a lesion here in the frontal lobe. This is frontotemporal junction. There's a lesion there, and this is a big lesion. There's a maybe edema here.
Okay.
So the most important this edema here, right? So there's edema, and there's a lesion inside the ventricle, right? The lesions are different size, and a lot of edema. So what is this?
So my thoughts.
Yes. So this is how the typical mass looks, right? Different sizes, gray white matter junction, and a lot of edema. So this is metastasis. We had this case yesterday. Did anybody remember? If you listen the lectures, you need to make this diagnosis. We had this yesterday. Yes, who said that? Yes. Why did you say lymphoma? Say one more time. Okay, what else? Yes. Yes. And something else. We just talked about highly cellular tumor. Remember the pineoblastoma? Yes. So it is dark on. Look at here, right? It is iso-intense to brain parenchyma. Most of the tumors are bright on T2. And if you do the CAT scan, it will be hyperdense, right? So there are few things are hyperdense on the CT. So that's why it's a lymphoma. Okay, so that's the lymphoma we talk about. So here's a case of the lymphoma where you see the hyperdense area, and this is in the area of the corpus callosum. And sometimes that's how it looks like, and you can tell that this is a highly cellular tumor. And then you can go further down and do the MRI and find out. But sometimes the CT scan is the clue. So we just saw the case of the seizures, right? So similar case here, where this is the axial flare sequence, this is temporal lobe with the expansile T2 signal intensity lesion causing focal mass effect. And so surgeons wants to biopsy this, right? Because they wants to know it's a low grade or is a grade 2 or grade 3. And the most important thing surgeons cannot tell, because it is located on the left side, they wants to make sure they are not touching what area comes here? We talked yesterday, right? And there's one area comes here on the back. Yes, so it's already here on the slide. But here is the Broca's area comes here, right? And it's the left side of the brain, and then the Wernicke's comes here. So we do the stimulation. This is a functional MRI, and they give the different tasks to the patients. They put the patient in the magnet, and there are a couple tasks they do. It's a fixed protocol what they do. There's a screen on the top from when like they're laying down, and on the screen they see the instructions. So they do the finger tapping. One thing motor sensation, like which are the area of the motor areas are lighting up. Then they speak some things, then they speak in the native language. For example, somebody testing me for the language, English is not my first language. So I need to trust in your mother language, whatever you learned when you were born. Those are the areas they taste, and the areas will light up. And so the light of if they try to do the biopsy of this tumor going from the front at the terion and coming down here, there's a high likely that they're going to damage this area. The person will be not able to speak anytime afterwards, after that, right? And so once we know this area, they try to get the approach and try to go from here or try to go from the back. So this is what we do with the functional MRI. That's what the multiplanar comes up, right? You see the 3 dimensions, and then put the tumors and do the functional MRI, which takes time, but interpretation is pretty important. When they said to do just the biopsy of the patients with the young patients with the tumor. And sometimes you see the tumor like this, where this is in parietal lobe, there is a high signal intensity, and they wants to go in, and they wants to know how far they wants to go in and dissect it out. They cannot go all the way down here, because in the DTI images, you see this touching the corticospinal tract. So if they try to go medially too much and try to take out the tumor, they might take out some of the corticospinal tract, and which is not good, right? Because the damaged part is going to be there forever. So they will be conservative and not try to touch the medial part of the tumor, and they will leave some tumor in. So they will be less aggressive and more conservative when they operate these tumors. And these are the DTI is not hard to get. If you have a software, you can get the images. Somebody wants to take this? These are the first one. If we want to take it's labeled here, right? It's post-op 5-7 months and after the radiation therapy. And I know you guys don't do the nuclear scan.
Dr. Bonsu online. Dr. Ajua Bonsu.
Who's doing online?
Yes, please.
Oh, okay.
If Dr. Bonsu is not, Dr. Oforida Akon.
So these are 4 MRI images. The first is an axial contrast enhanced. The first 2 A and B, in fact, ABC are contrast axial enhanced axial contrast enhanced images at the level of the centrum semi-ovale. And the last one is an ADC mapping at the same level. So the images.
Hold on 1 second. So this one is not the ADC image. This one is a PET CT image. So this first one is post contrast, post op. Then this is 5 months and 7 months, right? Axial T1 post contrast images.
Okay. 5 and 7. Okay. So the initial one, the A post-op, there's an area of hypointensity with minimal peripheral enhancement noted in the right frontal parietal lobe. There's minimal mass effect. 5 months post-op, there's an enhancing fairly defined mass noted in the same region with associated perilesional edema and minimal mass effect. 7 months post-op, this area of irregularly enhancing lesion has increased in size with mild associated perilesional edema and minimal mass effect. The PET CT shows this area to be hypodense.
So I don't know, you guys don't read PET, but the PET is metabolic active, right? So it's more active tumor. That's what it's showing, that is picking up, right?
Okay, so it's picking up.
metabolically active. Yeah.
Okay. So putting all together, I'll say that this is it gives a suggestion of a recurrence of the lesion, which is growing in size compared to 5 months and then 7 months. So in A post-op, it's looking like the lesion was completely resected, but in B and C, the lesion has recurred and has increased in size, although the patient had completed radiotherapy.
Okay, pretty good. So most important thing is they always do the post-operative imaging after they operate the tumor, right? Within 24 hours, because they like to see how much is resected, how much is the post-op changes, and they will do follow-up MR after a few weeks to see all the post-operative changes are gone. That's their baseline, right? So they know how much tumor is left, how much is resected. If there's a little bit enhancement there and it is not bright on T1, you know this is the residual tumor. Surgeons doesn't like to hear that, but if it is there on imaging, right? And so from residual tumor, if it is getting bigger size, then it is called progression. If it's completely resected and then the new tumor comes up, then it is called recurrence. Now, if you see the recurrence, then they need to stage it again. If you see the progression, they will keep continuing with the same staging, right? Because the grade matters how they treat the tumor. So that is important. And sometime after radiation, so this patient is 5 months after there was a tumor there and then it got bigger. The question comes up 5 to 7 months, is the tumor got bigger, residual tumor is progressed, but it is radiation necrosis, or it is the actual tumor. Okay. So they do different things to find out it's a progression or it is radiation necrosis. That's why it looks bigger. They can do perfusion imaging. They can do the PET-CT. They can sometimes do the advanced imaging like arterial spin labeling. Just try to see the perfusion, how much is the area supplying. Most of the cases, sometimes hard to find out that it's radiation necrosis versus tumor. And still that debatable what they do, multiple things they do. And ultimately they end up doing biopsy and they're treating the patients and following up, and then they decide. Most of the cases there's a tumor and necrosis both together. So with this one, what is this? Can you tell? So this patient has a tumor. They got radiated. See, there was a surgical sign here, right? The patient was operated. So you see this irregular enhancement like this after radiation. So this is typical of radiation necrosis. This is they call Swiss cheese appearance, right? All these small areas like necrotic and irregular shape. That's what you see with the radiation necrosis, right? So look like they call Swiss cheese soft bubble appearance. So if you see this, with this radiation, you need to put that in the diagnosis. There could be radiation necrosis, the actual tumor, and you follow that up. You see the patients after tumor surgery and radiation here, right?
Yes.
Yes. Okay, so the most important is the referring physician wants to know is the non-contrast CT. They always do non-contrast CT because they want to see how much is the hemorrhage, right? They like to know though is bleeding inside or no, there's a herniation and hydrocephalus is there or not. Unless the contraindicate, they always get contrast enhanced MRI, to look for there's only one lesion, there are more than one lesion. We talk about this, all this pseudo progression or the progression versus radiation necrosis. They do PET-CT. They can also do MR spectroscopy, and try to combine all these three together to differentiate between the real tumor progression versus radiation necrosis. Let's keep that. Okay, seizures and epilepsy. Your favorite. Somebody's favorite is this, mesial temporal sclerosis. Somebody love it here. Somebody said multiple times yesterday. The neoplasm in the seizure patient, we're looking for ganglioglioma, DNET, and others. Some vascular malformation can happen and cortical dysplasia. So this is all we look in the patient with the seizures. So what is this here? This is young patient with temporal lobe epilepsy. So somebody is going to take this.
Tenyo Tasiame.
You just assigning somebody? I hope I can do that.
If senior is busy, Dr. Adroa Bonsu. Otherwise, Dr. Marian Opariado. Dr. Ruth Badu.
Who's taking? Anybody wants to take it from here? No? We can take it together. Yes, go ahead.
Okay,
So there's the arrow, right? You can see the arrow.
Yeah, so this T1 contrast enhanced MRI is in the corner plane. So I think there's this well-defined lesion with increased T1, which is enhancing post-contrast administration, and this lesion is the temporal lobe. One hypo intense area. So I was thinking it's a cystic lesion with
Yes, pretty good description, right? Cystic nodule or cystic with the enhancing nodule in the temporal lobe, right? And it is involving, see, we talked yesterday, right? This is area temporal lobe, so this is hippocampus and amygdala. So this involving the both side, right? Up and below. So this is a typical appearance in the young patient with temporal lobe epilepsy. So what's the diagnosis? This is, anybody?
parasitic.
What?
Parasitic aside.
All right. So this is the ganglioglioma. Right? This is how it looks. And this is your favorite, somebody's favorite. Here you go. Somebody said it. So here you look for the fornix, right? The fornix is lower down. Look at the arrow, the fornix is going down. So that's give you the sign. And so there's a bright signal and there's a dilated ventricle. So that's what typically see with the mesial temporal sclerosis. And if they don't, so if you make a diagnosis, like remember we talked yesterday, if it's one side or both sides, you do the follow-up imaging, see it is not edema from the seizures or not encephalitis. And then it's staying there and there's a volume loss, phonics is down, you make a diagnosis after a few weeks or 3 months, and they try to operate. If they don't operate, that the seizure focus will travel to other side, and patient get the mesial temporal sclerosis other side. Other thing, if they wants to operate these patients, they do something called VADA test. You know what is that? So if they wants to remove the hippocampus, we talk about, there's a limbic system. So the memory is associated with the hippocampus, right? So if they try to remove this seizure focus, so by cutting out this middle temporal lobe, they wants to make sure that's not the dominant side. So what they do, they put the catheter, do the angiogram, right, in the internal carotid artery, and they try to block off one side of the brain. So they give the medicine phenobarbital, the anesthesiologist, and they knock down, then ask patient questions. They ask before, they shut down one side and ask all the memory questions. Then they do angiogram other side. They do the angiogram other side, and then they ask the same questions to make sure if they take out that temporal lobe, that he will remember everything. Otherwise, his life is miserable. He will not remember any of things, right? So that's what they do. So it's important to make a diagnosis and follow up also. Okay, so in summary, we talk about for brain tumors, we play a big role. Remember the common appearance, right? We talk about dural tail, all the classic findings we see on MRIs, and sometimes they do the preoperative MRIs for the preoperative functional MRI and DTI. The seizures and epilepsy, other things, there is dedicated protocol. In case of the seizure, they want to see the hippocampus nice outline symmetrical, so there is a separate protocol. We do the coronal T2 coronal flare to the hippocampus, which we don't do routinely with the normal routine brain or the brain tumor patients, right? So you need to get that done. Otherwise, you will not see that nice structure. You cannot diagnose mesial temporal sclerosis if you don't do it. And that's it for this. We'll take a break for 5 minutes, and then we finish the last one.
So we are going for a 5 minute break and then come back for the last set of questions. Thank you.
Itama. Yachayama. Itama. Yachayama. Bye bye, Aliway, Naya, the Lumono. Bakalika, yes, so Inaya, so Kakalika, yes, so Inaya, so my one blue. Gano dende, blaster so dende. 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 Yeita, mubi obabana bate the samia. Yachaga, mubi obabana bate the samia. Yeita, mubi obabana bate the samia. Yachaga. I bet the day in the money, I need Jan in the money. I say, Kofi in the money, I say, Mojan in the money. Winter in the money, and Stevie Nappy and the money. Robert Mesa, goalkeeper number one. The boy, a beshe, Yensulo Biala. The boy, a beshe, Yensulo Biala. The boy, a beshe, Yensulo Biala. The boy, a beshe, Yensulo Bialo. Yeita, mubi obabana bate the samia. Yachaga, mubi obabana bate the samia. Yeita, mubi obabana bate the samia. Yachaga. I bet the pain in the money, I need Jan in the money. I say, Kofi in the money, I say, Mojan in the money. Winter in the money, and Stevie Nappy and the money. Robert Mesa, goalkeeper number one. The boy, a beshe, Yensulo Biala. The boy, a beshe, Yensulo Biala. The boy, a beshe, Yensulo Biala. The boy, a beshe, Yensulo Bialo. Yeita, mubi obabana bate the samia. Yachaga, mubi obabana bate the samia. Mubi obabana, Yeita, mubi obabana. Mubi obabana, Yachaga, mubi obabana bate the samia. Mubi obabana, Yeita, mubi obabana bate the samia. Mubi obabana, Yachaga.
Yesterday we finished earlier, so we're going to finish late today.
Okay, so we are back from the 5 minutes break. We are going to continue from where we started from.
All right, so we continue now. The last lectures, the cellular and supracellular lesions. So the most important aspect is we need to recognize pediatric cellular and supracellular, because those play a key role, which are pretty important to identify, which is no any other way to find out except imaging. So this is a normal anatomy, right? We know the pituitary is sitting right there. What is this here? What? You are tea person or coffee person? Do people drink your tea or coffee? More coffee? What kind of coffee you guys drink? Just a simple guy. Nescafe. He's also questioning about that, so he's confused. But this a black coffee people. Oh. Yeah, see, I grew up in India, and a lot of people in US they drink like a black coffee. Just I cannot. I need to have a milk in the. I like tea, and I need to have milk inside. I need to have sugar inside. I need to have some spices inside. Otherwise, I don't know how people drink this black coffee. And I asked my friend. He said you get used to it, right? Because that's what you drink since the beginning. But it's pretty hard for me. So if I drink that, I will be more sleepy, then more awake. So the pituitary is located in this saddle-shaped depression, right in the midline, right here in the basal sphenoid, and it supports the front and back, right? So this front and back here, right? It's supposed there it's like a saddle, and the rider is the pituitary gland, right? So it has a adenohypophysis, neurohypophysis. We talked some of this yesterday, and this is how the saddle, right? This is how exactly the pituitary is sitting down there. So here it was say on the skull. This is the anterior clinar process, posterior. This is the pituitary sella turcica, and that's where the pituitary lies. And when you look at the skull X-ray, right, in the skull or in the scout images on the CT, there is a line. If they did a good lateral scout skull, because you will not see the outlining. You see like perfectly like this. Not overlapping another line. So we're going to go more detail about all the hormones, but all these hormones, right? We talk about prolactin, right? Prolactinoma, so pituitary microadenoma comes there. Also this ACTH, thyroid, that's why the hypogonadism things comes up, FSH and LH. The neurohypophysis we talked, somebody mentioned yesterday, I asked why the posterior pituitary is right on T1 because of neurosecretory granules. The pars intermedia is sitting in between the anterior pituitary and posterior pituitary. Hard to find out because sometimes there's a pars intermedia cyst which produce there, and that can be sometimes challenging to diagnose. So remember all these structures on the top. What is this structure called? What? Hypothalamus. Good, because this is the mass intermedia of the thalamus, right? So below this is hypothalamus. And this is here the mammillary body, right? So just the relationship showing this is the isthmus, which is the pituitary stalk, and the optic chiasm is come so close, right? Remember we talked just that's where the mass effect happens. And this is from coronal images, the sphenoid sinus. Remember the sphenoid sinus, this is the path where they go in. They go to the transnasal, to the transsphenoid, they make a hole here and take the tumor out. This is just the easiest way to take the tumor out. The other harder way is to go to the cranium, which is pretty tough. You need to go to the temporal lobe, right? So This is how the surgeon operates. So they like to know this coronal images. That's why we do images on coronal plane, because you can see the pituitary better. Do you guys do the pituitary protocol? MRI? Yes. Do you do the dynamic pituitary study for microadenoma? Yes. So here is the relationship, right? The cavernous sinus. So the cavernous sinus, there's internal cavity, but all these cranial nodes are sitting there, right? So that's important to find out whether the tumor is extending down there, or how much the mass effect, or how much circumference of the carotid artery if it is involved. So these structures are important for surgeons to know that there is an invasion or there is a internal cavity artery involvement. So here is the pituitary 3 months old. You remember we talked yesterday, it is going to be very bright because everything is growing. So that's normal. So don't call it abnormal at 3 months old. The 17 years old and the 15 months old. See, so normally you see the hyperintensive neonate, the normal by the age of 2 to 3 months, it is 3 months old, and then it become a globular shape like that, right? And then slowly it flatten out, and the size matters. So if you see the very good enhancing pituitary, you need to measure the size. If it is upper convex appearance, then we think about it's a hyperplasia, but you still measure the size. In the pre-puberty patients, like in the adolescents female and the male patients, at the time of puberty, you will see a little bit more bulky pituitary, right? Because it's growing. So that's normal. And then once you get the pregnancy time, also it gets a little bit bigger. But then after that, you get slowly slightly depression in the pituitary, which is normal. So that's what you need to remember, right? So how it looks. Again, they use the size. So 1 centimeter is the size they use. Sometimes in the pregnancy, they can use up to 12 millimeter, so that's bigger. So that matters when you call normal versus abnormal. So for example, this case, there is a 15-month-old, and you can see the pituitary is upward convex appearance and enlarging. So you measure there to there, and so this is how the pituitary hyperplasia looks, right? So this thing you need to keep in the mind, when you look at the picture. The 17-year-old is a rounded global appearance. So these cases are sometimes tough to say, right? And those cases, if you're not sure, the recommendations are you just tell them get the pituitary hormonal workup. So they draw the blood and get the hormonal workup. If it's abnormal, then you proceed further to get the detailed pituitary study. Now you're not going to get pituitary study right away, right? So this one you might be finding out just on routine brain. And that cases you want to know to go the next step, you need the blood workup. If there's an abnormality, then they will order pituitary studies. So this is how it normally development happen. The Rathke's spouse, right? That's where the we talk about Rathke's collapses. So the pause slowly regress, right? And then nothing left. There's a collapse left, but sometimes it persists, right? Sometimes persists, and this is how it happens. The floor of the third ventricle goes down. The invagination happens, and it goes down. And this part here, the collapse, Rathke's spouse goes up, and this combine, and then you form this pituitary here, and slowly this part goes up, so this part will regress. Basically you get this part which is blue, and on the left part, these both are separate in starting time and then combine. And sometimes this clap persists, that's where the pars intermedia cyst comes out. So it's important to know this anterior posterior part. There's a neural stalk. This is called adenohypophysis, neurohypophysis. And this is all you get better in the sagittal images. You separate out anterior and the posterior lobe. So the pathology, these are the different conditions can happen in the pituitary. So congenital abnormality, the one which is transmenudal encephalocele, in that case there's a persistent craniopharyngeal canal. The other one is this Rathke's collapse cyst and craniopharyngioma. This is pretty rare. Duplication hypoplasia is very rare because there's a lot of clinical findings go on with the hypoplasia particularly. There is the empty sella turcica happen, which is significant if it is happen in the pediatric patient. So here is how the full separation happened, right? So this canal here will persist, and then it doesn't fully involute, and that's where the problem happens. So it's showing the case here where like you hardly see the pituitary here, right? So there's a persistent canal, like this bony canal will persist here. That's what you see on MRI, and pituitary is absent here, right? So if doesn't completely involute, then you don't see the pituitary there. The pituitary hypoplasia is very rare, and if you have that abnormality, then you start seeing all other abnormality, like you will have an absent usual high signal of the posterior pituitary, and it is easy to find out because you need to see bright pituitary in the neonates, right, up to 3 months, and if that's absent, you know something is wrong. And then along with that, you will see most important is a hypothalamus abnormality, because all things are developing together, and you will have other midline abnormality in the craniofacial and orbital abnormality. So if you make a diagnosis of pituitary hyperplasia, you need to make sure you look at all the midline structures. The septum pellucidum, remember the third ventricle is right there. So optic nerves are also there because optic chiasm is just above the pituitary. So you look at all these things for the pituitary hyperplasia. So here is a pediatric patient with the 2-month-old, right? 2-month-old, what we like to see, very, very bright pituitary, right, which is not there. So this is what you see with the growth hormone deficiency, right? And there is maybe a suggestion that this posterior pituitary dot is higher up, so there may be ectopic pituitary over there. And here is another case where you definitely see the bright dot of the pituitary is higher up, so that's the ectopic posterior pituitary. The duplication is a part of the median cleft syndrome, and this is very rare. If you see, just keep it there. So this is where you see the 2 stalks coming out, and you see the big stalk. You see, you even don't see the bright dot of pituitary because everything is abnormal. So the stalk is pretty bright here, and they get craniofacial abnormality. So Rathke's cyst, right, which we see, which is the embryological remnant, and you can see in all ages, right? You can see in pediatric also. So you make a diagnosis when it is not enhancing, there is no calcification, there's an intracystic nodule, right? Cyst with intracystic nodule. These are asymptomatic, so they don't do anything. They look at the pituitary function. If there is abnormality, then they can operate, right? If the pituitary abnormality is causing the dysfunction, then they will operate. So this is how it looks. Commonly, it's like here, the suprasellar area, rounded cystic area, and in the midline, and it will not enhance. It's following the fluid signal. Sometime if you see there will be small nodule sitting inside. That's what you will see. Cyst with the nodule. You see here the bright signal. Anybody know what is this? No? What? Yes. So there is something called patient with diabetes insipidus, right? You could have an increased signal intensity in the posterior pituitary. So that time it looks like this, So they like to know, and you can make a diagnosis of diabetes insipidus on the basis of there's an increased signal in the posterior pituitary only, not anything in the anterior. Okay, so remember the Rathke's collapses, right? It's in differential diagnosis, always this. So whenever there's a cystic lesion happen in the pituitary, right, you need to differentiate it out, whether it's a Rathke's cyst, it's a cystic pituitary adenoma, or pars intermedia cyst, right? The pars intermedia cysts are small cysts happen in the midline between anterior and posterior pituitary, right, exactly in the midline. Let me use this. Yeah. The cystic pituitary adenoma in the 10% of the cases. So those cases are tough to diagnose, and they usually happen in the anterior lobe, which looks like a cyst, and you can only give a suggestion. This could be cystic pituitary adenoma versus Rathke's cyst, right? And so what about cystic craniopharyngioma? Now, cystic craniopharyngioma is very rare, right? Because when you talk about the cystic pituitary adenoma versus the Rathke's collapses, you're talking about adult population, right? That's where you make a diagnosis, because pituitary adenoma is not common in the pediatric population, right? The pediatric population, you talk about Rathke cyst, pars intermedia cyst, and cystic craniopharyngioma. So those are the three things you look for. The craniopharyngioma you can diagnose by, you see the solid enhancing component inside and calcification, not like cyst with the nodule, it will be a solid component. And you see calcification, you will not see calcification with any of these other conditions. So that brings your type down to craniopharyngioma. Craniopharyngioma are the slow growing benign tumors, right? There are two types I call A type and P type. One is a papillary type, this adenomantinomatous type, which is typically in the children. That's what we see, and papillary type is common in adults. And so pediatric patient come with headache, visual disturbances, and short stature. This is typical presentation. And 5 to 10 years of the age. See the second peak, which is adult, which is a different appearance in the 6th decade. So what you see, remember, calcification is your key. Calcification, multilobulated, multicystic mass. Papillary one is a solid and rarely calcified. So that's completely different appearance. So this is how it looks. 10-year-old, right, axial CT, you see the cystic mass, the peripheral calcification, there is a hydrocephalus, looks like a diffuse brain edema, I don't see any sulci. So this is midline mass, so you worried about what? You worried about cellular, supracellular mass, like craniopharyngioma, teratoma, right, germ cell tumor. And the next step, you do the MRI. So an MRI, you can see there is a cellular mass, supracellular extension is going all the way involving the overlying the third ventricle. That's why you don't see the thalamus area. The body of thalamus is covered. The surgeons like to know whether it is involved the third ventricle or not. They change their approach. So they will pinpoint and ask you, do you think it's involving the third ventricle or not? And sometimes it's hard because you see it is overlapping the third ventricle, right? It is not invading. It is just overlapping that area. Sometimes you see the claw sign and you see this is going like other direction, and then you can say third ventricle is involved. They change their planning. So this is the typical craniopharyngioma, the cystic, the solid component, and cause hydrocephalus, and there is a transepithelial CSF flow here. Sometime you can see the robust case where the cystic component can expand, and I have seen the cases where the cystic component can go all the way and go over the brainstem. Just keep expanding, unless they take it out. And those tumors are pretty recur. Those are very hard to treat, and they recur. That's the other problem with the craniopharyngioma. Okay, anybody wants to take this? Yeah.
So this is a serial MRI images, mid-sagittal T1. The second is T1 with contrast, and the last is T2. So we see a large ovoid-shaped lesion in the cellular supracellular region. That is T1 hypointense with rim of hyperintensity. Then on a T1 post-contrast, we see rim enhancement, which is complete enhancement. Then on T2, it is hyperintense. So it follows fluid signal. So with these findings, I make an impression of cystic pituitary adenoma.
Wow, cystic pituitary adenoma. I still have a hard time finding those cases. So remember, this is supracellular, right? Other thing is this is not in the pituitary, right?
Okay,
so when you talk about pituitary adenoma, it likes to come from pituitary, right? Inside the pituitary and go up. So this is completely supracellular, right?
Okay.
I don't see the stalk. So
Rathke cleft cysts.
what? Rathke is okay. I can get that. Rathke cysts you can have. This is a bit more practical, right? Anything else?
Oh.
This is not the same case, right? So I'm showing you how the cystic pituitary adenoma looks. So you see that it's coming from down there and going all the way up, right? Right. So that's how the, and sometimes you see the, hard to see the pituitary one, and there's a massive optic chiasm. So that's the prolactinoma. So you come back to this. So so this could be Rathke's cyst. Yeah, I can buy that. This is a lymphocytic cyst, lymphocytic hypophysitis, and which can happen in the female population. So sometimes it looks like this, just involving the pituitary stalk, nothing else. Okay, so intracellular, supracellular mass, like these are all the diagnoses, right? Rathke's cyst, pars intermedia, craniopharyngioma, and adenoma. So the talk about infundibulum. Do you guys know anything about infundibulum? What should be the normal thickness? So normal is like 1 to 2 millimeter. You cannot have more than that. If it's thick or nodular, remember we had a case where the pituitary hypoplasia and it was absent or double stalk. You can see the thick stalk. So those you need to watch out for it. The normal anatomy is tapered down from superior to inferior. It goes down. The signal intensity of normal stalk is really less than the optic chiasm, and less than of the normal neurohypophysis in all the cases. When the signal intensity is changed, then it's abnormal. So the pathological spectrum of pediatric infundibular disease, right? So this is, we're strictly talking about pituitary stalk, right? 61% of the cases you see here. What is this? Do you guys see pediatric cases right here? Yes. So do you do pediatric report pediatric pituitary problem? Yes. Okay. So the most important thing is to make sure all these tumors are not there, right? See, so also the lymphocytic hypophysitis, right? So these are the common things you see. Let's show some examples. So here's a patient with the idiopathic central diabetes insipidus, right? So they already give you a diagnosis. So this is how it looks. So pituitary is normal right there, and the stalk completely abnormal, right? And the protruding and causing mass effect. So this is also along the posterior part of the pituitary, right? So that's called infundibular neurohypophysitis, right? Have you guys seen the case like this? No. Pituitary stalk can also enhance with the LCH, Langerhans histiocytosis, right? So that's one of the cause of the pituitary stalk abnormality, and you can have a white matter abnormality with that too. Then it brings down to the point of the germ cell tumor. They are the midline, right? All the midline tumor in pediatric, we talked about germ cell tumors. So most frequent in the pineal area, right? We just saw the case of the pineoblastoma. Similar, the germ cell tumor can come there. The next is the supracellular, right? So there's always some differential. The more in the Asian population, the pineal tumor is the male predominant, and the supracellular germ cell tumor is not predominance. So if you're a male patient in the pineal tumor, you think about germ cell tumor. So this is classification for germ cell tumor, germinoma. You know why it's important to make the diagnosis of the germinoma versus teratoma? How the teratoma looks on imaging?
So you have some classifications of tissue component.
Yes. And the germinoma? So why it is important to make the diagnosis on imaging is the teratoma versus germinoma? So teratoma you can tell, right? Because you see the fat, you see the calcification, right? So it's teratoma. The germinoma, particularly because they respond well to chemotherapy. They're not supposed to biopsy if you say the germinoma. If you say teratoma, they will go in and take it out. Germinoma they need to wait because they respond well with the treatment. So the surgeons like to know that. And they can run some test and try to find, but on imaging, you have a particular appearance, so you can tell. So germinoma is common, right? Germ cell tumor, 40% of the cases. Then all other tumors are hard to find out, which one it is. And remember, 10% of the all intracranial germ cell tumors happens in the pineal area and also in the neurofacial hypophyseal area. So you look at the both area together to make sure that you don't miss one versus another. There, somebody says it's a multicentric origin, somebody says it's a dissemination, from above to below. About 50% of the germinoma and 90% of the germ cell tumor has a cystic component. So that's another thing to look at. It doesn't matter the cystic component you found, that means it is going in other direction. So here is a case with sagittal T1, right? And what is this area here? We talked about yesterday. Nasopharynx, right? So this is not abnormal, right? This is the adenoid, which is commonly seen in pediatric population, right? So that's not the tumor. So the tumor we have is here, right? This is sagittal T1. And you contrast, you can easily see there is a big tumor right at the pineal area. Hard to see the tactile plate. It's overlying the midbrain, also going overlying the vermis and close to the straight sinus. So the straight sinus is maybe a piece there. Oh my God. Sorry. There's a time difference between there and here. All right. And then you see there's another lesion right here, the suprasellar area, right? So there's a pineal tumor and there's a suprasellar tumor. And the T2-weighted image, look at the tumor. Tumor is iso-intense. Remember highly cellular tumor we talked about, like lymphoma, right? Meningioma could be like that, right? So those tumors, the similar here, highly cellular tumor and surrounding there's edema, right? And it's causing mass effect, and that's why you see the hydrocephalus. And this is a suprasellar area tumor. So this is how the pineal tumor with the multicentric origin, right? Is one here and one there, and so these are how the germinoma look. This is typical germinoma. So here again the same thing. The mass is in suprasellar and going and involving the hypothalamus, and going all the way there. And look at the pineal area. Pineal area looks okay. Maybe there's a pineal cyst there, and it's going higher up, right? So there is a mass effect, and surrounding you see all this edema. So remember, this is a midline tumor, this is a germinoma, these are not juvenile pilocytic astrocytoma, right? So you need to remember that all the midline tumors are not all the GPA, so the typical germinoma. So here again, the suprasellar, and here is going down there, right in the pineal area, right there. So remember this one, 23-year-old with the primitive neuroectodermal tumor, right? So it is in the midline, but the difference part here is there is maybe a little bit calcification there on the non-contrast CT. So, and also there is a seeding. So if you look at here, there is some enhancement along the spinal cord, right? So already CSF dissemination happened. So sometimes you cannot make a diagnosis. It's a germinoma, it's a peanut, but most important is this thing, right? Where the CSF spread happen or not. So it's important to report those findings, and if you cannot tell clinically or radiographically there is this is a germinoma, you can just report what you see, that there is a tumor. It doesn't look like teratoma, or it is a teratoma, or you cannot make a diagnosis. Sometimes it stops like this and it turns out to be peanut, right? But the most important thing, you're helping out by this dissemination. So we saw this morning, right? Remember optic pathway glioma with the NF1? There was a case, right? There was a retrochiasmatic tract was involved, and it is well-defined mass, invariable enhancement. And these tumors are slow growing, right? So they can happen on one side or both sides, and most patients have a visual loss. And they can involve the optic chiasm. So this is how it looks. So this is the coronal images, and you see this is a part of the prechiasmatic area, right? And then it will go one slice next and it become optic chiasm. So that's enlarged on both sides. And you can see the surrounding signal intensity like this we saw this morning, and sometimes there's a patchy enhancement along the retrochiasmatic tract. So these are the optic pathway glioma. Hematoma, I think I saw this case, hematoma. It was a little bit different case, but I think was in the first lecture, right? So hypothalamus hematoma, precocious puberty, right? Patient come with the what seizure? Elastic seizure. There we go. So another tumor, right? Again, but this is located where? So here is the one tumor which is located into the supracellular area going in the hypothalamus, right? It is highly cellular. There is a hydrocephalus, there is a transhypothalamus CSF flow, and there's another tumor down there in the supracellular area, and another tumor you can see here, down here, right? So these are the different cases, right? See one here, and this one is a different case. So all these, right, when you see the tumor in the midline, just try to look at the pineal area, try to look at the hypothalamus, and you mention all these differential diagnoses like germ cell tumor, germinoma, or any of the mixed tumors. Anybody know what is this? Yes? Who say that? Who say that? Good, very good. So remember, see there's a flow, there's a area here with surrounding bright signal, right? You always need to make sure there is no aneurysm, and if you look at here, right there on the T2, you can see the nice flow void. So this can fool you. The T1 weighted images can make you fool, you know, because if you have thrombus aneurysm, it can look like bright on T1, right? But then you look at axial, then you can see this is coming out aneurysm right there. So important to remember the normal appearance, right? The congenital cyst, all these tumors, germinoma, peanut, hypothalamic hematoma, we talk about ectopic pituitary and the dermoid. So this is for today. And tomorrow we're going to have a lot of case discussion about tumors. So look it up. It will be fun because tumors are a fun topic. And ask any questions if you guys have. You're welcome. Yeah, the good.
Okay.
Okay.
Okay. Thank you so much, Prof.
You're
We are
welcome.
grateful for your insightful lectures and all the knowledge you have imparted. Learned a lot on the supracellular imaging and then the tumors and the pineal gland. We are very grateful. Please, if there are any questions, those online, any questions? Okay.
Here. Any questions online? He's in charge of IT. Not yet.
Okay, so as we check for any questions online, there are a few announcements that we should take note of. We are reminded to register for the CPD points. If you don't register, you don't get your CPD points. And if you register and then you join the Zoom meeting, kindly use your full name. And those who don't register and then join with the link, please use your full name. Otherwise, you will not be able to join the meeting. So the best is to register so that you can have your CPD points. And also, after every session, there are some questions that are asked. I think there are some post session evaluation forms that are also put on the page. Then we are asked to fill for each day. So yesterday they put some links on the page for evaluation. Today too, we have the same thing. So we are all encouraged to fill the evaluation forms after each session. Yes, I think that's all for today. So this one has come to an end all too soon. Thank you all for your participation, those online and those pages. Tonight. Thank you all. Thank you so much.
So this what is this called? Credit CPT?
The CPD, yes.
CPT,
CPD point.
CPD. Well, it's like a CME,
More like continuous.
continuous education. So how many you guys need to finish?
15.
1-5. So if they attend this one, they get 15.
I'm not sure, but we have other
Or you don't know how much you're getting from this
That's
one.
it.
You don't know?
Working on it. Do you know the CPD point for this?
Last year we had about 15 points.
Yeah, because if they attend, okay, let's get 15 done.
Yeah.
Yeah. Because like in 2 days, like, I don't know, I just saw more than 200 people, you know. Right? That's still many. Like, it's just, you're not going to see this many cases in the one season, you know. Right? But you go with yourself. Oh my God, it's too much. Right?